అయినా చూడు.
Hmm? Participation. नाम चेंज करो तो बेहतर नाम नीचे अटेंडेंस है फिर और ये नाम चेंज
How much? Ask me.
Good morning. Good morning, ma'am. Shall I start presenting?
Good morning.
My name is Anisha. I'm a second postgraduate of Katpagavanayada Medical College.
Excuse me, Dr. Anisha. From the organizer, anybody is there? From the organizer, anybody, like committee, anybody is there, or we'll start, or we'll wait for them? Nobody is answering.
Good morning, ma'am.
Good morning. Yeah, can you start or we'll wait?
Yes, ma'am. We can start, ma'am.
Yeah, my co-judge has not yet joined. That's okay. We'll start or. Can you make your slide little like font size little bigger, like enhance it? Dr. Anisha.
Yes, ma'am. Yes, ma'am.
Yeah. Can you start or we'll wait?
Yes, ma'am. Oh, 2 minutes, ma'am. We are contacting the other judge, ma'am. 2 minutes.
Yeah.
Good morning, ma'am. Yes, ma'am. We can start the session, ma'am. The other person.
Okay, so who is going to see the time? Please put a bell like before the timing, because somebody has to see the time also. Can you hear me? Yeah, from the organizing committee, somebody has to just note to see the timings. Yeah, Dr. Anisha, you can start.
And we can start the session, ma'am.
Yeah. Okay, she can start.
My name is Anisha. I'm a senior postgraduate of Karpaka Vinayaga Medical Institute. Today, my poster presentation on endometrial adenocarcinoma with adult granular cell tumor. It's a case report. Introduction. Endometrial adenocarcinoma is the most common malignancy of the genital tract. Granular cell tumor of the ovary accounts for 2% of all ovarian tumors. About 70% of the granular cell tumors secrete estrogen or androgens. Most commonly, the ovarian and the endometrial tumors are well differentiated endometrioid adenocarcinomas of low stage, resulting in excellent prognosis. Ovarian cancer is usually discovered as incidental finding and is diagnosed at earlier stage because of symptomatic endometrial tumor producing bleeding. If it is poorly differentiated or if uterine and ovarian tumors are histologically dissimilar, the prognosis is less favorable. Case Mrs. Rani, wife of Shivan, 60-year-old P1L1, hailing from Changalpeta, who belongs to socioeconomic class 3, postmenopausal by 10 years, no comorbidities, presented with an episode of postmenopausal bleeding associated with passage of clots continuously for past 2 months. There was no associated abdominal pain, weight loss, or loss of appetite. Gives history of changing 4 to 5 parts per day. Also gives complaints of increased fatigue and breathlessness since the last 2 days. On examination, she weighed a 60 kg and height 153 centimeter. She was clinically pale with a hemoglobin of 5.5 gram per cent, which was corrected by blood transfusions. Examination, general condition was fair, afebrile, pallor present, no pedal edema, and no nodes palpable. Her abdomen, soft, non-tender, no organomegaly, no fluid thread. Per speculum, cervix not visualized. Per vaginal examination, cervix mid position, firm, hard in consistency, uterus anteverted, bulky, fornicis free, and bleeding period plus. Per rectal examination, bimanual rectal examination normal. Investigations, basic investigations, complete hemogram done showed severe anemia, and peripheral smear done showed microcytic hypochromic anemia with thrombocytosis. Liver function test and renal function test and thyroid function test are normal. Ultrasound abdomen and pelvis revealed bulky ovary 4.4 into 2.8 centimeter, uterus 8.1 into 4.7 with endometrial thickness of 20 mm. People's endometrial biopsy showed clear cell carcinoma in the background of atrophic endometrium. Cervical biopsy revealed chronic non-specific cervicitis. Endometrial biopsy revealed atrophic pattern with focal metaplastic changes. MRI pelvis done showed uterus of 9.2 into 5.5 into 6.3 centimeter. Endometrium measures 4.5 mm in thickness with loss of endomyometrial interface on the posterior aspect of the body with T2 bright signal foci in the posterior myometrium. Multiple Nabothian cysts noted in the left posterolateral aspect. Right ovary of 4.8 into 2.9 into 3.6 centimeter, enlarged with multiple varying sized follicles. Left ovary could not be visualized. Minimal free fluid in the pouch of Douglas. Impression arised. Endometrial clear cell carcinoma. Laparotomy done. Laparotomy findings were right ovary of 5.5 into 4 centimeter enlarged. No adhesions noted. Body of the uterus normal. Left ovary enlarged with multiple follicles. Lymphadenectomy done. Infracolic omentectomy done. Peritoneal fluid and all specimens were sent for histopathological examination. The histopathological report showed cervix chronic non-specific cervicitis with benign endocervical polyp, endometrium, endometrioid adenocarcinoma grade 1, myometrial invasion.
Your time is up now.
It's time for discussion.
Yeah. So, Dr. Anisha, it's a good case, good presentation. I just wanted to ask one question. When a postmenopausal bleeding, when it is 20 mm, is it ideal to go for a people biopsy?
Ma'am, no, ma'am. Endometrial biopsy is what we have to do now.
Yeah, endometrial biopsy we have to do. There is lot of several methods of doing an endometrial biopsy. When it is 20 millimeter, like is it ideal to go for a people biopsy or any other mode of biopsy you are supposed to do?
Like dilatation and curettage you can do, ma'am. Fractional curettage, ma'am.
No, in a postmenopausal lady, we don't do a dilatation curettage. Either you do a hysteroscopy guided biopsy or you do a fractional curettage. Because when it is 20 mm, it may be a polyp and it may be a growth also. So people sometimes you may miss the exact pathology. Luckily, you got here like clear cell adenocarcinoma, but chance is there you may miss. Okay, and yeah, so preoperatively this granulosa cell tumor was not diagnosed.
Yes,
Isn't it? Okay, so histopathology only showed it was a granulosa cell tumor, and the contralateral ovary,
yes, ma'am.
that is pre-op tumor.
Yes, ma'am. It was free of tumor, ma'am.
Okay, okay. And what stage it was?
Stage 1, ma'am. Grade 1.
Stage
Yes,
1A. Okay. Okay. So how we are going to follow up this patient?
ma'am, we have asked the patient to go to a nearby hospital for on-call just setup, ma'am. Whether if they need to start on radiotherapy or chemotherapy, ma'am. We have also sent the slides and the block and slide with the patient, ma'am. And we have asked her to come to us for 6-monthly follow-up to see how the patient is doing, ma'am.
Okay. And another thing I just wanted to in a clear cell carcinoma, endometrial carcinoma, you are supposed to do also a para-aortic lymphadenectomy, because even if it is stage, because chance of lymph nodal metastasis is more common in a like all these type 2 tumors, and prognosis is also bad. So you are supposed to go for it, because once you are known, biopsy report has come clear cell carcinoma, you might have done a MRI and CT, but you have not
Yes,
mentioned, I think.
Ma'am, we have done, ma'am, all late pelvic lymph node study showed only reactive features without any metastasis.
Yeah, that's good. Finding has come as negative, that's good. Okay, Senthil, any question?
No, I only had one doubt. In a postmenopausal woman, what type of malignancy do you expect? Forget your GCT. What do you expect? You are thinking a 20 mm. 20 mm endometrium. Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah, what do you usually expect?
Endometrial carcinoma, ma'am.
Which type, ma? Endometrial cancer, though we know when it's 20 mm.
Squamous cell carcinoma.
Squamous cell?
Endometrial carcinoma, you will get a squamous cell, which is most common type of endometrial carcinoma.
Why are you stuck? Okay.
Carcinoma. Adenocarcinoma.
Yeah.
Thank you. Thank you.
Thank you, ma'am.
Thank you.
Next candidate, Dr. Akshita. Can you start? Akshita. Akshita, can you share your... Dr. Akshita?
Yes, ma'am. Ma'am, I am sharing PPT.
Yeah, share your.
PPT to PD.
I can see your Lopamudra. Is it our Lopamudra?
Lopa, if Senthil.
No, I think my name is coming as Lopa, isn't it?
Yeah, you changed the name.
Yeah. I just noticed. Why I'm thinking Lopa is joining from somewhere.
Dr. Akshika. Dr. Anushree. Dr. Anushree,
Yes, ma'am.
can you please share
Hello?
your PPT?
Yes, ma'am. Am I audible, ma'am?
Yeah. Your presentation timing is 3 minutes. Okay, so please stick
Yes,
to the
ma'am.
time.
Okay, ma'am. Good morning. I'm Dr. Anushri. I'm from AG Institute of Medical Sciences. My topic for today's poster is a case of monochorionic twins with Dandy-Walker syndrome. The classic Dandy-Walker malformation is going to be defined by a cystic dilatation of the fourth ventricle, an enlarged posterior fossa, elevated tentorum, and complete or partial agenesis of cerebellar vermis. The etiology of it could be chromosomal abnormality, single gene disorders, or exposure to teratogens. The prevalence of it is 1 in 30,000 births and found in 4 to 12% of all cases of infantile hydrocephalus. Sonographically, the fluid is going to be enlarged cisterna magna, visibly communicating with the fourth ventricle through the cerebellar vermis defect, with a visible separation of the cerebellar hemispheres. The case is diagnosed in utero or in the neonatal period. Nearly 40% are going to die, and only 75% of survivors are going to exhibit cognitive deficits. My case is a 33-year-old gravida 3 para 2 living 2 with previous 2 LSCS and hypothyroidism at 19 weeks and 5 days, who came for a regular ANCHR hospital. An anomaly scan was done, which was reported as twin live intrauterine fetuses, monochorionic and diamniotic, with fetus A corresponding to 19 weeks and 6 days and fetus B corresponding to 19 weeks and 5 days, with Dandy-Walker spectrum in both the fetuses, with occipital meningocele in fetus A. She underwent hysterotomy. 2 male fetuses weighing 400 grams and 410 grams each were extracted with a single placenta. Her postoperative stay was uneventful and she was discharged on post-op day 5. The Dandy-Walker syndrome is a malformation of the brain, which usually occurs during the embryonic development of the cerebellum and the fourth ventricle. It is diagnosed by ultrasonography, CT, and MRI. The prenatal sonographic diagnosis is fairly simple, but the differential diagnosis like megacisterna magna and retrocerebellar arachnoid cyst are important. The expectant mother can be offered an amniocentesis to test for any chromosomal abnormality. Most children can have evidences of long track sinus, cerebellar ataxia, and delayed motor and cognitive milestones, probably due to associated structural anomalies. The Dandy-Walker malformation is usually managed by shunting of the cystic cavity, either a ventriculoperitoneal stunting or a cystoperitoneal stunting in the presence of hydrocephalus. So the conclusion is that the prognosis is going to depend on the hypoplasia of the vermis and the presence of associated malformations. Due to poorer prognosis, the possibility of termination can be considered in these patients.
Yeah, thank you, Dr. Anushri. Yeah. So Dandy-Walker syndrome usually it is more common in monochorionic. It is compared to a normal singleton pregnancy, or it is more common in a monochorionic twin.
It is more common in monochorionic twins.
Yeah, it is almost 200 times more common. And usually it happens with, can you tell me some conditions where with monochorionic twins this Dandy-Walker syndrome occurs?
It's usually associated with teratogenic exposure or chromosomal abnormalities.
Yeah, mostly patient will be having like like a TTTS of like particular some stages, or maybe associated with IVT. Usually it affects the donor twin, but here both the twins had the Dandy-Walker syndrome, isn't it? So one more question I just wanted to ask: why this patient in a previous scarred uterus, is there any other method of terminating the pregnancy other than hysterectomy?
Ma'am, I can't hear you.
No, in a scarred uterus, is there any other method of terminating the pregnancy other than hysterectomy?
Since this patient was previous to cesarean sections, we prefer to take her up for hysterectomy.
Yeah, hysterectomy you can do. I'm not denying that. I'm telling, is there any other method that is also indicated in a scarred uterus? because it is hardly some 20 weeks pregnancy.
Ma'am, induction of labor can also be done.
Anushree, you have to sit somewhere where your network is good. You're not
Yeah.
audible at all.
Yes,
Your
ma'am.
voice is breaking in between.
Yes, ma'am. Yes.
Yeah, you just tell little loud. Your voice is also little low. Yeah, any other method? Yeah, hysterectomy is one of the method. We don't deny it.
He's
Any
asking
other
you
method?
what are the other types of second trimester MTP. Understood the question?
In a scarred uterus. Can you do any mechanical,
Okay,
any
ma'am.
drugs?
Sorry to interrupt, ma'am. Time is up, ma'am.
I have only one advice for Anushree. See, your discussion is fully pediatric. Your discussion should have been more fetal medicine and
Yes, ma'am.
obstetric. Your
We can
discussion is fully
induce
pediatric.
labor by giving misoprostol, ma'am.
No, this is an ob-gynae conference, no? So
Or Foley's catheter induction can be done, ma'am.
Yeah. Police catheter, you can give a mifepristone, not misoprostol.
Foley's catheter induction can be done, ma'am.
Okay, thank you.
Thank you, thank you.
Dr. Arularasan, can you kindly share your PPT?
Good morning, ma'am. I'm Dr. Arularasan. Here be sharing the PPT,
Okay,
ma'am.
ma'am.
Am I audible, ma'am?
Yeah, you are audible. So make your slide little bigger so that we can see.
Good morning, all. My name is Dr. Arularasan J, second year postgraduate from the Indira Gandhi Medical College, Pondicherry. My
Can you
topic
make
is
it?
transfer.
Okay, yeah, present.
My top.
Your poster is
Full
not
screen. You make it full screen because we are able to see only half of your poster.
Yes, sir. Yes, ma'am.
No, still I think, yeah, now, but you make it a bigger size.
Okay, ma'am. My topic is transfiguring teratoma. That is,
No, you are not able to see the letters, France. You make it in
poster
a
is
full.
not visible.
See, poster is visible in a very smaller font size. We are not able to see. Can you make it as a full screen?
I kept in full screen only, ma'am.
But it's coming like in a vertical mode and half of the screen is visible. Means once you are making it zooming
You
in.
zoom one side and then you finish and then you go to. Are you all presenting from phones or iPads?
Phones, ma'am.
Fatima Zohara, whoever is there, Fatima Zohara, please mute yourself.
See, while presenting, always you should log in through a laptop, particularly when you are presenting.
Okay, ma'am.
Yeah, now it is okay.
Now it's partly visible, yes.
Now tell
Okay, ma'am. Good morning, ma'am. My topic is transfiguring teratoma. That is how a teratoma changes itself, or how diverse clinical manifestation a teratoma can have. We are having some 5 cases. Teratomas, that is, it accounts for 10 to 20% of all ovarian neoplasm, with incidence of bilaterality accounting for 8 to 15%, and malignant transformational teratoma accounting for 1 to 2% of the cases, and 2 to 5% of the ovarian teratomas undergo tumor ovarian changes. To our knowledge about this tumor types is limited basically on case reports and case studies. Our first case is a 45-year-old female who's postmenopausal with complaint of lower abdominal pain and abdominal distension for 1 month, showing an enlarged mass corresponding to 20-week size of gravid uterus. The mass is felt separately from the uterus, concluding that it's an ovarian mass. Radiologically, the mass is a cystic mass of size 11 cross 11 centimeter with solid elements with tumor markers within normal range. Staging laparotomy for the mass was done, and the histopathological report showed squamous cell transformation of the mature cystic keratoma of right ovary. The other ovary is normal. Our second case is a 34-year-old multiparous operated for cystic teratoma in outside hospital. She came with a histopathology report showing a poorly differentiated squamous cell carcinoma arising in dermoid cyst. So total abdominal hysterectomy with sulfingo-oophorectomy with omental biopsy was done. Our third case is a 38-year-old sterilized parous woman with history of abdominal distension, difficulty in breathing with a normal uterus, and left adnexal mass. UST showing a left adnexal mass measuring 9 cross 6 centimeter. CA 125 is highly elevated, that is 709. So exploratory laparotomy was done, and histopathologic examination showed stoma ovarian changes. Fifth case is a 22-year-old Paris with the complaints of secondary infertility. Examination showing a mass of size 7 cross 7 on right ovary and 4 cross 4 on the left side ovary. So intraoperative bilateral ovarian cyst was found, and bilateral ovarian cystectomy was done. Histopathology report showing dermoid on both the ovaries. Discussion being, germ cell derived tumors are nearly 20% of all ovarian tumors in adults. In about 95% of these germ cell tumors are mature cystic teratomas. It's composed of well-differentiated tissues from at least 2 of the 3 germ layers, and with wide spectrum of presentation from asymptomatic and incidentally detected to conditions associated with severe complication like malignant transformation cases. Malignant transformation occurs, as we already seen, a malignant transformation occurs in 1 to 2% of the ovarian teratomas, with a squamous cell carcinoma accounting for 80 to 90% of the malignant transformation. Rokitansky nodule or dermoid plug, that is shown in the first peak of our poster. Rokitansky nodule or dermoid plaque is the most common site of malignant transformation. Only 1 to 2% of the squamous cell carcinoma cases can be diagnosed preoperatively. Stoma ovarian is a very rare monodermal teratoma, accounting for 3% of all mature teratomas. Frequently present with features suggestive of malignancy, as in our case with the elevated CA up to 705, but it's just a stoma ovary, not a malignant condition. It is important to diagnose this preoperatively, especially in young patient, to avoid radical surgeries and following complications following surgery. Concluding, teratomas may have varied presentation and diverse presentation clinically, radiologically, biochemically, and pathologically. So it is important to recognize it to provide optimal management surgically and adjuvant therapy is needed. Thank you, ma'am.
Yeah, thank you, Arun. Like teratomas, usually it is like more common in a reproductive age group, and usually it comes as a benign. But all your cases, I think in the young age, 34, 38, like 3 cases have come as malignancy, isn't it?
Yes, ma'am. Yes, ma'am.
None of your patient is more than 40 years group.
Yes, ma'am.
Yeah. So once you are showing like so pre-operatively, how can you like diagnose this is as a malignancy?
Pre-operative, we have to clinically we have to examine the abdomen, ma'am. If the consistency of the mass is cystic or solid consistency, if we are suspecting the mobility is restricted, if we are suspecting adherent to some retroperitoneal masses,
no, in
or
any
if you
of your patient, did you find any malignant, like suspecting malignancy?
Yes, ma'am. Yes, ma'am. In the first patient, UST, in first patient, sonographically, we found some, in addition to the cystic mass, we found some solid masses, ma'am. So it kinked.
No, in a dormant, obviously there will be some solid components will be there. How do you differentiate? In like there will be some like if tooth is present, you will see some solid mass or solid nodule you can see.
Yes, ma'am. Ma'am, if there is the solid mass associated with septations, that's all. Those indicates transformation to malignancy, ma'am.
Okay. So any of your cases needed after like most of the patients belong to which stage? All these 3 patients.
Stage 1A, ma'am, of ovarian cancer.
Okay, stage 1A. Okay.
Sorry.
I have a question, Aruna Rasan. How many dermoids do you operate in a year? Say, for example, what is the rate of, you're saying a very high number of malignant dermoid, which is very unlikely, or by the textbook, it's very unlikely. Okay.
Yes, ma'am.
So if you probably have done hundreds of dermoids and 5 turned out to be malignant, or what? How many have you done? Do you have a number?
Yes, ma'am. In our setup, we usually account for some 10 to 15 per month, ma'am. That's it. It's a high number, ma'am. Yes, ma'am.
Alone.
Yes, ma'am.
Okay. So out of the 10 to 15 dermoids, 1 turns out to be malignant, is it?
Yes, ma'am.
No, this whatever cases you have taken, you can tell no over a period of years. Over a period of
how many years have you taken?
Over a period of 3 years, ma'am. These are starting
over a
from
period of 3 years, you got 4 malignant cases out of how many dermoid? Or how many ovarian tumors operated? That you should have shown, would have been much better.
Around, yes, ma'am. Around some 300, ma'am. Over the 3 years, over 300, ma'am.
300 dermoids.
Yes, ma'am.
Okay. What if you're saying whatever you're saying is correct? Then it's a good number to be presented in an international forum. Please do.
Okay, ma'am.
Okay. if the number is correct. All right.
Okay, ma'am. Okay,
Please
ma'am.
discuss with
Anyway, I'll refer with my guide, ma'am.
Yeah,
Yes,
yeah.
ma'am.
Yeah. Thank you.
Thank you. Thank you.
Thank you, ma'am.
Dr. Deepika, can you kindly share your PPT? Deepika, Dr. Deepika.
Yes, ma'am.
Share your PPT. Dr. Deepika,
Yes, ma'am.
Dr. Deepika,
Ma'am, yes, ma'am.
can you share your PPT?
Ma'am, 1 minute, ma'am.
One request to all the presenters, please log in through the laptop and keep your presentation ready.
Dr. Deeksha, can you start your PPT?
Yes, ma'am.
Sudha ma'am, can you forward that mark sheet mail to me? I have not received it.
Yeah, I'll send.
Dr. Deeksha,
Yes, ma'am. I'm sharing it, ma'am. Sorry, ma'am. I'm having some trouble to share the screen, ma'am. Sorry, ma'am.
Dr. Janvi,
Yes, ma'am.
can you share your PPT?
Yeah, ma'am.
Until I have sent you to that OBGY MGMC RIDL.
Okay, ma'am. Okay, ma'am.
Okay. The mail has not gone to you because it. I think it has gone only to me.
SENTHIL, ma'am, it is. SENTHIL, it is. SENTHIL COUMARYA.
No, I have sent to you that OBGY MGMCRI.ac.in.
Okay. Oh, it is HOD mail. Okay.
Ma'am, I'm sharing my screen, ma'am. Are you able to see this, ma'am?
Yeah, we are able to see. Ma'am, your title is not seen.
This is Dr. Jana, PG from SC Medical College, Tirupati. I am going to present a poster regarding a rare case of hypokalemic paraplegia during pregnancy, which I noticed in my hospital. Coming to the case, it is a 27-year-old gravid 6 para-3 live to death on abortion 2 with previous to normal delivery. Then abortion a year ago unbooked case presented with 8 months of amenorrhea with history of low weakness since She was being treated for severe preeclampsia since 7 months and on treatment with labetalol and nifedipine. There was no similar episodes in the past. On admission, we have noticed that they revealed edema with grade 2 and blood pressure of 150 by 100 mm. On optic exam, 34-week gravid uterus with longitudinal lie, cephalic presentation, and her LFT RFT were within normal limits. They have done fundoscopy for her, which was normal, and pitamixan was given for fetal lung maturity. We have taken the physician opinion regarding this, and they have noticed the tone and the power of both the lower limbs were normal, but there was off the knee and the ankle reflex. We have sent electrolyte profiles, which revealed that potassium level is 2.5 milliequivalent per liter, ma'am. And then meanwhile, we sent MRI brain, which is expected to be normal. As per the advice of the physician, we have given an oral syrup Portro 30 ml TID along with the hypertensive drugs, ma'am. And the pregnancy we have continued for 1 week, and the lady spontaneously stepped into the labor, ma'am, and she delivered a male child of birth with 2.3 kg with good upcurve. And postpartum period was uneventful, ma'am. By daily potassium levels monitoring, she revent to the normal position, ma'am, and her weakness decreased gradually, and the potassium levels become normal with syrup Portro, ma'am. And coming to the discussion, it is a hypokalemic paralysis. It is a rare channelopathy caused by skeletal muscle mutations, commonly calcium channels and sodium channels. It is characterized by episodic severe muscle weakness. May range from numbness or weakness to complete paralysis. Hypokalemic paralysis during the pregnancy is very rare. It manifests as acute muscular weakness associated with low potassium levels. And any pregnancy is high risk, but pregnancy associated with this kind of paraplegia is a high risk pregnancy. Normally, during the pregnancy, lower limb weakness is common due to the pressure of the uterus over the nerves in the legs, which causes the numbness and tingling in the legs and toes. But eventually, it will vanish post the delivery. So it is imperative for the both physician and obstetrician to have knowledge regarding the causes of the hypokalemic paralysis. Coming to the etiology, it may be varied, ranging from congenital to acquired. So the detailed history is needed to rule out the differential diagnosis. In this case, the patient presented with hypertension and hypokalemia, which includes a differential diagnosis like congenital adrenal hyperplasia, Liddle syndrome, primary hyperaldosteronism, Gordon syndrome and Geller syndrome, and familiar hypokalemic periodic paralysis.
Time for discussion.
Yeah, Dr. Janal. Yeah, it's a good case. Yeah, I just wanted to, can you tell me some common like predisposing factors for this hypokalemic paralysis during pregnancy?
Yes, ma'am.
While taking a history, if you are finding this kind of like hypokalemic paralysis, you have to take typical some history so that you can know maybe that is a risk factor. What are those risk factors?
Ma'am, for this patient, there is no risk factor regarding the hypokalemia, ma'am, but she has presented with hypertension associated with this hypokalemia. Usually, it will be during pregnancy, it is presented in Geller syndrome, ma'am, due to the progesterone. But here, maybe because of the less intake of the potassium content, also it may lead to the hypokalemia. But we didn't find any risk factor regarding to this.
No, your patient might not be having. Your patient might not be having. I am asking in general.
Ma'am, it may be due to congenital disorders, ma'am.
No, there are some common reasons like if the patient have a prolonged traveling or previous like dehydration or any vomiting, that also can give rise to hypokalemia. We have come across one case, patient did not have any other factor other than the prolonged flight traveling. Because those are very common factors, like very silly factors, but still you should know what are the common factors that can give rise to hypokalemia. You told this patient is severe preeclampsia treated from 7 months. Means?
Yes, ma'am. Yes, ma'am.
Severe preeclampsia, 7 months means like around 28 weeks is severe preeclampsia. Pregnancy was continued till 34 weeks.
Yes, ma'am. She came with
answer. How can severe preeclampsia be treated for 6 weeks, Amma? Think and answer.
6 weeks.
You only said from 28 to 34 she's having severe preeclampsia.
Yeah. And she is on treatment, you are written till since 7 months.
Sorry to interrupt. Time up, ma'am.
Ma'am, she came to us at only at that time only, ma'am. But she is having BP since 7 months, ma'am. She is unbooked case, ma'am.
No,
She
that's
can
okay.
have hypertension, but she will not be severe hypertension. Okay.
Okay, okay.
Okay. Thank you.
It's 3 more than 1.
Thank you, ma'am. Next.
Thank you.
Dr. Jean Sarapal, can you start your PPT?
Yes, yes. Am I audible?
Yeah. Go ahead.
Yeah, please go ahead.
My poster is on going incognito, HPE disease, a rare case report. HPE disease is an autosomal recessive hemoglobinopathy and is caused by the mutation of codon 26 of beta globin gene. It's seen most commonly in southeastern population. In India, it is prevalent in West Bengal, Jharkhand. Most people with HBE disease remain obscured from diagnosis due to lack of boisterous symptoms. The various genotypes of HBE disorders include heterozygous type AE, homozygous type EE, and compound heterozygous state, that is HBE, along with any other abnormal genes, all of which results in a clinical spectrum ranging from mild to severe symptoms. My case report, a 32-year-old gravida 2 para 1 living 1 at 30 weeks, originally from Bangladesh, presented to the OPD for a regular antenatal checkup. Pala was noted on examination, and investigations done showed moderate anemia with a HB of 7.2 gram per deciliter. And she, despite being compliant to her iron and folic acid supplements, obstetric history, she had delivered a male baby of 4 years old, 4 years, by full-term vaginal delivery. There was history of blood transfusion antenatally in the previous pregnancy in view of anemia. Baby is alive and healthy. No history of jaundice or retarded growth or abnormal facies in the baby. The investigations that we sent, hemoglobin was 7.2 gram per deciliter, PCV of 27.9%. The blood picture showed microcytic hypochromic anemia. And as you can see in the peripheral smear picture, there were presence of target cells and elliptocytes, and Menser's index was less than 13. And they had suggested hemoglobin electrophoresis, for which HBE electrophoresis of the mother was done. In that, HBE was 94.5%, HbA2 of 5.2%, and HbF of 0.3%. The management hematologist opinion was sought and was advised to continue iron and folic acid supplementation. Was asked to maintain HB of more than 8 gram per deciliter and plan to transfuse phenotypically matched packed cell RBC to avoid alloimmunization. And she had also advised HB electrophoresis of the husband and fetal thalassemia status to be assessed after 1 year of birth. Pediatric hematologist was also consulted for the same and was explained the chances of the fetus being a carrier or having a thalassemia trait, depending on the father's electrophoresis report. Antenatal scan for fetal well-being was also done and was normal. The discussion, the burden of anemia in India is among the highest in the world. And patients...
Discussion.
Hello?
You please continue, please continue.
Yeah.
The patient's chronic anemia, despite compliance to oral hematinics, led to the incidental finding of HBE disease. Further exploration into this disease, which is increasing in prevalence, may lead to many a breakthrough in the diagnosis and further management of these cases and their possible complications.
Yeah, thank you, Dr. Jean. So I just wanted to ask one question. How do you suspect this patient to be like hemoglobin HBE disease?
Actually, when she had...
yeah.
when she had presented to us, she had presented with moderate anemia, and she had given a history that she has been regularly taking her iron supplements. Like when we had
diagnosed in the last pregnancy having hemoglobin HbA,
no, ma'am, no, no, but she had given a history of blood transfusion prior to delivery in view of anemia.
That is fine. I just wanted to know how, like, why did you suspected this patient to be having, because it will be diagnosed mostly by the electrophoresis, or do you routinely do for all anemia patients like hemoglobin electrophoresis?
No, ma'am. We had done our peripheral smear. In the peripheral smear, the blood picture showed target cells, and Menser's index was also more than 13. So they had suggested to do a hemoglobin electrophoresis. More than 13 is it's supposed to be less than 13. If it's more than 13, it can be a thalassemia trigger or any other hemoglobinopathy.
Yeah, that was
more likely to be.
Because how like it is different from the other type of anemia.
Yes.
Got my point. That's why because
Yes,
we don't do for all patients hemoglobin electrophoresis.
No. Yes, ma'am.
Yeah. So, is there any like specific effect on the baby?
Hello.
It's an autosomal recessive disorder. So, if the father as well is carrying a defective gene, then the baby can have anemia. It depends on the. It can either have a trait if it is only getting the gene from the mother, or it can have a mild anemia, splenomegaly. But all this is noted only 1 year after 1 year of life.
Okay, thank you.
No, I have no questions. Thank you.
Thank you, ma'am.
Jean Sayed, you share your PPT. Hello.
Okay.
Dr. Jean Sayed. Akshika, right? Dr. Akshika, right?
Hello, good morning, ma'am.
Good morning.
Good morning, ma'am.
Hi, I'm Sayed Jigni. Today's my topic is a study of ectopic pregnancy in post-victimized women. Introduction: and ectopic pregnancy occurs when fertilized ovum implants.
Dr. Syed, can you make it full screen?
Yeah, ma'am.
But once you're making half of the slide is, yeah. I think you are doing from
introduction. Yeah. Introduction: and ectopic pregnancy occur when fertilized ovum implants outside normal uterine cavity. Female sterilization is an effective method for permanent contraception. When it fails, there is conception, which is likely to be an ectopic pregnancy. Risk factors are previous ectopic pregnancy, tubal sterilization, tubal corrective surgery, infertility, PID, smoking, and prior abortions and prior deliveries. The incidence of ectopic pregnancy after tubal sterilization is 7.4%. Aim and objectives: the study was done to determine the incidence, risk factors, clinical features, treatment, mortality, morbidity associated with ectopic pregnancy in tubectomized women. Methods and materials: 3 cases of ectopic pregnancy in tubectomized women were studied. Case 1, 25 years P2L2A1 with previous 2 LSCS with mini laparotomy sterilization 7 years back, presented with history of pain, abdomen since 1 month, and 2 episodes of bleeding per vagina. UPT was positive. USG shows echogenic lesion 3.3 into 1.9 to 2.4 centimeter in right adnexal region with surrounding echogenic fluid collection. Treatment: emergency laparotomy with right salpingectomy, intra findings, uterus bulky, under ectopic pregnancy in right ampullary region, right ovary, left tube and ovary normal. Post-op period was uneventful. Case 2, a 23-year-old with T2L2 with 2 previous LSs with tubal sterilization done at the time of cesarean section 6 years back, presented with pain, abdomen, spotting per vagina since 1 day. The patient was very pale with HB 5 grams. UPT was positive. USG shows empty sac in left adnexal region surrounded by clots and free fluid with internal clots, hemoperitoneum present. Treatment: emergency laparotomy with left salpingectomy, intra finding, last 2 to 2.5 liters hemoperitoneum neutered. Noted ruptured ectopic pregnancy in left side isthmus region, minimal adhesion and features of PID seen. Right tube and ovary normal. Post-op 2 units of blood transfusion given. Case 3, 35 years old, P2L2 with 2 normal vaginal delivery, had postnatal tubectomy 14 years ago, presented with pain abdomen radiating to shoulder tip since 1 day. Patient was pale with HB5, UPT was positive. Ultrasound showed ruptured tubal pregnancy in right adnexal region. Treatment was emergency laparotomy with right salpingectomy. Intra-op finding 1000 ml hematoperitoneum present, uterus 6 to 8 week size, ruptured ectopic in right ampullary region, left ovary and tube normal, post-op 2 units of blood transfusion given. Results in my patient, all 3 presented with abdominal pain, 2 out of 3 present with bleeding for vagina, 1 out of 3 present with shoulder tip pain, 3 out of 3 vital stable, 2 out of 3 were anemic. Etiology, 2 to 3 pelvic surgeries, 2 out of 3 were previous LSCS, 3 out of 3 were tubal surgeries. 2 out of 3 were right-sided ectopic, 1 out of 3 were left-sided ectopic site, and 2 out of 3 were ampulla, and 1/3 is isthmus. On laparotomy, massive hematoperitoneum is seen in 2 to 3 cases, and PID 1 to 3 cases, ovary normal in 3 to 3 cases. Salpingectomy done in all 3 cases. Post-op blood transfusion was done for 2 to 3 cases. Conclusion, early diagnosis, identifying risk factors, and timely intervention help to reduce mortality and morbidity in ectopic pregnancy. The management of ectopic pregnancy is by use of conservative surgical and medical methods by salpingectomy was a treatment modality which was used in present study.
Yeah, thank you, Dr. Said. I just wanted to ask you one question. What is the importance in your study?
Ma'am?
What is the importance?
Continue sharing screen. Suddenly your poster went off.
Don't stop.
Stop sharing, please.
Yeah. So what is the importance in your presentation? Why did you
Prevent the risk. I mean, to reduce the mortality and morbidity of ectopic pregnancies, ma'am.
Yeah, this is, see, ectopic in a tuberculosis patient, it is one of the risk factors. And once you want to study the incidence risk factor, you have to take a 3 cases, means it is not even in making it a case series. Got my point? So you have to take a lot number of cases, then you can study the incidence, risk factors and everything. And this is a quite normal for a tuberculosis patient, which is one of the risk factors to have a ectopic pregnancy. And because it's already, it is in a previous tuberculosis patient, you have to go for a salpingectomy. There is no question of doing any conservative management, isn't it?
Yeah. Yeah, ma'am.
So
only in an unruptured ectopic pregnancy, we can go for conservative management.
Yeah, and that too, in future you want to study, you please take number of lot of cases. It is not only 3 cases. So
yeah, I wanted to say the same. If you would say a study of ectopic pregnancy and you present only 3 cases, this is case series. This is not a study of ectopic pregnancy. Okay, the title, that's why I wanted to see the poster again. The title is not into what you're presenting. You're presenting a series of 3 cases, post-tubectomy patients having ruptured ectopic. That is all.
Yeah.
All right, so that's not a study. All right, it's just a case series.
Okay.
And your conclusion has got nothing to do with the title.
Yes.
Okay. All right. Okay. Please look into it. Yeah. Thank you.
Rakshika Patel, can you share your PPT? Dr. Rakshika Patel.
Yes, ma'am, I am sharing PPT.
None of the presenters are showing their video.
Doctor, go to back, open your presentation. First open your presentation. Yeah, open that.
पीडीएफ ने पेज खोला
ना खुली गई પણ અહીંયાની માઈક ઓન કરવું પડશે ને તારું
कर दीजिए
You don't have an open
Good
file?
morning. Hello.
Yes,
The
tell
slide
me.
is not seen.
Can you close your screen and
report.
open your presentation PPT mode?
My presentation is open.
No, your desktop
You
is
are
showing
not able
there.
to see your presentation.
Open your presentation and then in PPT mode and then put share.
Presentation PPT.
Go back to Zoom and then give share.
Am I visible?
You
My
are not
No,
visible. Your slide is also not visible.
Sorry, ma'am.
your presentation is in a PDF or PPT mode.
I think it is in PDFs. Yes, good.
Okay. Do one thing. You put it in a chat box. I can download and I can share it.
Dr. Kavya, can you share your PPT?
Yes, ma'am.
Yeah.
Okay. This is
My
good.
slide is visible.
Visible.
Yeah,
Go
yeah.
ahead. Go ahead.
Good morning, ma'am. A case report on hydatiform mole. Myself, Dr. Akshika Patel from PMCH Udaipur. Molar pregnancy is a part of gestational trophoblastic disease. It is abnormal condition of placenta where there are partially degenerative and partially proliferative changes in young chorionic villi. In India, incidence of hydatiform mole is 1 in 500 to 1000 pregnancy. A 47-year-old female, para 6, live 6, residing at rural area came in OPD with complaint of 7-month amenorrhea, abdominal pain, and bleeding PV since 5 to 10 days. Patient's past medical and family history are remarkable. Her UPT was negative. On examination, patient was stable. Her vitals was normal. On per-abdominal examination, uterus was 30 to 32 weeks. Dowgy filling. On per-vaginal examination, os closed. After this, patient was admitted and laboratory results are as follow. Hemoglobin 6 gram, WBC 4600, platelet 1.06 lakh, INR 1.18, beta FCG 53,866. On sonography, a large mixed echogenic lesion with internal multiple areas in endometrium cavity causing its significant expansion known as molar gestation, possibly complete hydatiform mole. Patient was transferred to OT for suction and evacuation. Patient was also transferred 4 unit PRBC, 4 unit FFP and 4 unit RDP. Then patient was transferred in ICU under observation for 1 day. Her HPR report confirmed complete hydatiform mole. Patient was discharged after 2 days. She was followed up serially till her beta FCG values were unremarkable. Gestational trophoblastic disease is one minute.
Yeah, we can see your slide.
Gestational trophoblastic disease is term used to encompass a group of tumors typified by abnormal trophoblast proliferation. Gestational trophoblastic disease histologically divided into hydatiform moles, which are characteristic by presence of villi, and non-molar trophoblastic neoplasm, which lack villi. Hydatiform mole include benign condition like complete hydatiform mole and partial hydatiform mole, and malignant condition invasive mole. Non-molar trophoblastic neoplasm include choriocarcinoma, placental site trophoblastic tumor, and epithelial trophoblastic tumor. Hydatiform moles are most common form of benign gestational trophoblastic disease. Complete hydatiform mole have 15 to 20% incidence of malignant sequence compared to 1 to 5% following partial hydatiform mole. Conclusion: beta FCG value can lead to enormous false negative urine pregnancy test. Thus, proper workup and sonography is needed for diagnosis of hydatiform mole. In rural India, awareness of antenatal care visits and perimenopausal visits are required for early diagnosis of hydatiform mole.
Can you start with the discussion, ma'am?
Yes, ma'am.
Yeah. So, like Dr. Rajani, thank you. So, I just wanted to know, see, the 47-year-old female, when you are suspecting she's having a molar pregnancy, what other investigation you should have done? And what is your, like what you are suspecting in a 47-year-old when you are suspecting it a mole?
47-year-old.
Is it normal?
With amenorrhea, ma'am, 47-year-old with amenorrhea?
No, I mean to
You are having a case of molar pregnancy and she's 47 years old. What else will you suspect? What difficulties or what problem?
Ma'am, molar trophoblastic neoplasm is more common.
Yeah, so to rule out that, have you done any other investigation?
Ma'am,
Isn't choriocarcinoma common in these patients? She's so old, isn't it? She's 47 years old. She's perimenopausal. Won't you think of choriocarcinoma?
alpha beta protein.
Yes
Yeah,
or
you
no?
should have done. Have you done a chest X-ray?
No.
Yes, ma'am.
Where is it?
Yes. You are not mentioned anything regarding the investigations. And in a 47-year-old with the molar pregnancy, we are not going to do a suction evacuation for her. What treatment? I do know what are the risk factors, the Pigo scoring system. We don't do a suction evacuation in a 47-year-old with a complete wound.
No, ma'am. Ideally, we will do hysterectomy.
Yeah, but yeah, you have to also rule out choriocarcinoma before that, isn't it?
Yes, ma'am.
Yeah, but you have done a suction evacuation.
Yes,
because this patient's follow-up, you know, on a 47 years, that, or maybe your age is wrong. I don't know.
Patient refused, ma'am. Patient refused to do hysterectomy, so suction and evacuation.
See, patient is refused to do. You have to tell the patient what is the prognosis, isn't it? Patient refused. You have to counsel the patient accordingly. And when she has come with like 30 to 32 weeks of uterus.
Yes, ma'am.
You got my point. It is not.
Yes,
you,
ma'am.
Yeah, you know better than the patient what is the like prognosis and what is the side complications. So you have to counsel the 47-year-old why she won't be agreeing for hysterectomy. Already she's para 6, life 6.
We don't know what difficulties you have practicing in Udaipur. All right. So you tell me your conclusion, is it in any way correct? Is it in rural India that awareness of ANC and perimenopausal visit is important? Yeah. Family planning is important for this patient.
Family planning is important.
Why won't you people counsel? I don't know if people accept it or not. Isn't there a good family planning program? She's a para 6, life 6.
Life 6.
Yes, ma'am.
Is it very difficult in Rajasthan to counsel patients for sterilization?
No, ma'am, but patient's relative refuse for sterilization, ma'am.
No, now there's no point doing sterilization. She's 47. Ideally, hysterectomy would have been a better option for her.
Yeah.
Isn't it? Is she going to come back for follow-up?
And that's what you were telling. She has come from a rural area. Then how you were expecting she will come for a follow-up? Subsequently, she will develop like choriocarcinoma.
Sorry, ma'am, I am unable to. Ma'am, patient follow-up weekly. Yeah. Hello, ma'am.
Yeah, you are audible.
Tell.
Ma'am, patient follow-up weekly until its beta SCG are unremarkable, then monthly up to 6 months.
No, that is the protocol. But if your patients are like she is coming for regular follow-up, when the patient's attenders are not willing for a sterilization after delivery, for being para 6, life 6, and they are not willing for a hysterectomy, knowing it is a like complicated, it's a molar pregnancy at such a old age. And do you think this patient will come for follow-up weekly to you?
No.
No. Then ideally you should have counseled the patient in that way so that you could have done a hysterectomy for her.
Yes.
Okay. Okay. Thank you.
Yeah, doctor, stop sharing. Madam judges, good morning. I'm Tirupati R. Madam, we would request you to the presenter. They should open their video, ma'am.
Yeah, I'm also telling let them, but nobody is presenting the video.
It's a mandatory, otherwise they will not get a certificate.
Okay.
Yeah, please, they should open their video. Make it slideshow.
Dr. Diksha?
Yes, ma'am.
Yeah, you can start presenting.
Good morning. This is Dr. Diksha from Bangalore. So today is my case report on a case of facial diplegia, which is following a surgical stress. So introduction about the case is bilateral lower motor neuron facial palsy is a very rare condition. It's a very rare condition which is comprising less than 2% of the cases. Most of the cases have underlying medical conditions like infections, neoplasia, trauma, metabolic disorders, and most patients with facial diplegia are usually benign and self-limiting. So some causes will be like the GB syndrome, multiple idiopathic renal neuropathies, brainstem encephalitis, the Miller-Fisher syndrome, associated intracranial hypertension, Hansen's disease, cryptococcal meningitis with acquired immunodeficiency syndrome, and tuberculous meningitis are those with infectious etiologies. Some rare causes of this facial palsy will include diabetes, sarcoidosis, head trauma with severe neuropathy. Bilateral symmetrical facial palsy is unusual and an ominous sign which requires a complete evaluation for etiology. So our case report was a 25-year-old female who was admitted in the OBG ward at Akash Institute of Medical Sciences and Research Center for wound infection following a lower segment cesarean section, which was on day 10. Initially, a medicine opinion was sought and the patient came with complaints of slurring speech in terms of unable to pronounce words clearly, difficulty in closing eyes, difficulty in chewing food since 2 days. She had undergone an LSCS a week ago and there was no complication which was noted during the antepartum and immediate postpartum period. However, there was no history of any fever, headache, seizures, head trauma, or weaknesses of upper and lower limbs. On examination, a physical examination did not reveal any evidence of Hansen's disease. A CNS examination was done, which revealed bilateral lower motor neuron facial palsy. All other cranial nerves were normal, with no other neurological deficits. Cardiovascular system, respiratory system, and on perabdomen examination was normal. So hence, clinically, it was diagnosed to be a facial diplegia, and a further workup was done to identify the cause. Lab investigations like a complete blood count, LRBS, LFTs were done, which was normal, and MRI brain revealed no commentable abnormalities. Nerve conduction studies and EMG showed delayed motor latencies with denervation changes in bilateral facial muscles, which suggest a lower motor neuron facial nerve palsy. So on conclusion, it was a rare case of facial diplegia following a surgical stress. However, a good improvement was observed in recovery, which you can see here. The recovery was much better on the left side more than the right side with steroids and physiotherapy. However, as per the literature, the known causes were worked up and all were found to be normal. Therefore, post-surgical stress could be the etiological factor in our case. Coming to the discussion, unilateral facial nerve palsy is a common neurological disorder which we encounter with an incidence of 25 per 1 lakh population. Facial diplegia represents...
Yeah, thank you, doctor. In a presentation, will you present the conclusion first, then the discussion?
First, the conclusion.
First, you will present the conclusion, then you will go for discussion.
Ma'am? No, ma'am, I'll be first presenting the discussion and then the conclusion.
But you presented exactly the opposite. You presented the conclusion first, then you are going for the discussion, isn't it? Yeah. And you have to make the slide in such a way so that discussion should come first.
That you won't make mistakes when you're presenting, because when you are under pressure when you're presenting, no, if it's in an order, you will present correctly.
Yes, yes.
Put in the wrong order, you will do the same thing.
Okay, you should have put in below the examination. You should put the discussion at the right side of the PPT, like your poster. You should have put the end. You should have put the conclusion. That is why I thought you will go to the discussion, then you will come to the conclusion. But you presented conclusion first, then you went to the discussion.
Sorry, ma'am. I'll make a note of it, ma'am.
Okay. So your patient, you didn't find any other neurological cause of facial diplegia except the surgical stress. Okay, this this picture, this is after therapy.
Yes, ma'am. This is after the one with the scarf is after therapy, ma'am. We put her on prednisolone, 10 milligram per kg per day for 6 days, and then we taper the dose for 10 days. So the one with the scarf, you can see that there is recovery on the left side, ma'am. The Bell's phenomena is not there on the left side.
Show the picture of a bilateral. This is only unilateral.
Ma'am, the picture next to that, ma'am, is bilateral where Bell's phenomena is positive in both the eyelids. And the picture below also, you can see that there is no frowning which is seen over the forehead.
Okay, Senthil, anything?
Yeah, my only question is, why did you decide it's because of surgical stress? And this happened 10 days post-surgery. And why would you call it surgical stress?
Ma'am, that's because we tried to follow up other causes. We did she was not positive for HSP also. We have done an RBS, which could even be because if she's a over diabetic or a known diabetic, that was also negative. And we thought it could also be because of HELLP syndrome. So we did all other causes also, but we didn't find anything.
Okay. And you said she came back with wound infection to the ward.
Yes, ma'am.
So what
Sorry.
Okay.
Ma'am?
Okay, fine. Thank you. Thank you.
Yeah.
Dr. Kavya,
please stop sharing. Yeah.
Dr. Kavya.
Yes, ma'am.
Share your PPT, please.
Dr. Kavya, open your video also, please.
Is it visible, sir? Screen.
Yeah. Screen is visible. Open video, please.
I on. Can you see me, sir?
No, your video is not on.
I on it actually.
No, your video is not visible.
Now, ma'am?
No.
No. Okay, your bandwidth is low. Okay, let's start the session presentation.
Okay, sir.
Yes,
Please
start
start.
the presentation.
Yes, sir. Good morning, ma'am. I'm here to present a rare case of MRKH syndrome. Introduction. Mayer-Rokitansky-Kushner-Hosner syndrome, MRKH, is a rare disorder described as aplasia or hypoplasia of uterus and vagina due to an early arrest in the development of Mullerian ducts. Women with this syndrome are characterized by the presence of 46 XX karyotype, normal female secondary sexual characters, normal ovarian functions, and underdeveloped vagina. The presence of leiomyoma in MRKH syndrome is very rare, and only few cases have been reported in the literature. My case, a case of 37-year-old female with primary amenorrhea. Sorry, ma'am. A 37-year-old female with primary amenorrhea and primary infertility presented with abdominal pain. She is phenotypically female, has well-developed secondary sexual characters, and has normal female external genitalia with shallow vagina dimple. Transabdominal ultrasonography showed multiple fibroids in anterior and posterior myometrium with echogenic lesion of 4.3 cross 2.5 centimeters seen in the right adnexa. Endometrium could not be delineated. A large heterogeneous mass of size 6.9 cross 6.2 centimeters in pelvis is demonstrated by MRI. We proceeded with exploratory laparotomy.
Yeah, make it the slides, sir. Slides, sir. Yeah.
We proceeded with exploratory laparotomy, showed torsion of ovary, torsion of right adnexal mass, torsion of right adnexal mass with hypoplastic uterus and fallopian tubes with blind end and absent cervix. Both sides ovaries are normal. Removal of right adnexal mass with preservation of hypoplastic uterus, bilateral fallopian tubes, and ovaries was done. The histopathological examination showed leiomyoma arising probably from the broad ligament. Discussion. The origin of leiomyoma in MRKH patients includes multiple uterine remnants, which is around 65%, fibrous myometrial bands, the broad ligament, the round ligament, vascular leiomyoma, and parametrial tissue. Leiomyomas can grow because of estrogen stimulation, considering that patients with MRKH have ovaries with normal hormone levels. Pelvic MRI may be helpful to differentiate a myoma. Excision of the myoma and adjacent uterine remnants with or without salpingo-oophorectomy is the minimum surgical intervention. Thank you, ma'am.
Yeah, thank you, Dr. Kavya. So, pre-operatively, you have diagnosed this patient as a MRKH syndrome, isn't it?
Yes, ma'am.
Yeah. So, why you have mentioned this adnexal mass? It is a broad ligament fibroid, isn't it?
Ma'am, we were not sure where the mass arising from because it was actually presented from the left side, ma'am. But in MRI, they have mentioned it as right side.
Okay. So, intraoperatively, it was a right side and right side.
Right torsion. Yes, torsion. It torted to left hand, which was actually arising from the right side, but it torted to left. That's why she's having pain.
Why was the hypoplastic uterus preserved? She's 37 years old.
37 years, yeah.
Yes, ma'am. Actually, there was no added benefit of removing the uterus as well, ma'am. So
there's no added benefit of leaving the uterus behind also.
Yes, ma'am.
No, I'm generally asking. Maybe there was no consent or something.
No,
so
ma'am. We haven't we just removed the mass and we came out, ma'am, because we thought like there was no added benefit of removing it or preserving it as well. Actually.
Okay. What about the ovaries? Yeah.
Ovaries were retained, ma'am.
Okay. You said there's torsion of the right adnexal mass, isn't it?
Yes, ma'am.
Okay. So there's torsion. Was it an acute emergency or something?
No, ma'am. She was just presented with pain abdomen. It was not an emergency procedure, ma'am. Because
it's quite confusing. You say it's a broad ligament mass, and then you say it's undergone torsion. That's why I'm asking you all these questions.
No, ma'am. Actually, it was twisted 2 times, and patient complained with pain abdomen, which we actually managed with medications. Then it settled, ma'am. So we have taken it as an elective procedure.
No, you have taken it elective procedure, that is fine. Our doubt is intraoperatively, you have written the torsion, but broad ligament fibroid, it will be a sessile fibroid. How it has undergone torsion?
The whole mass, which I have shown in the picture, torted, ma'am, actually, along with the pedicle.
Along with the pedicle?
Yes, ma'am.
How broad ligament fibroid, it will be a pedicle, like pedunculated fibroid. And you have not shown that this is the ovary. You know, this is the hypoplastic uterus, isn't it?
Yes.
No, she's holding the fibroid.
Fibroid.
Yeah, this is the fibroid.
Yeah, the
This picture,
forceps,
what is
I
it?
think, is the hypoplastic uterus. Yeah.
This one? This one? This person? Yeah. The second picture.
Second picture, they are holding the mass.
Fibroid.
Fibroid.
This one? This small one? Yeah.
That small one is ovary, ma'am.
The small one is the ovary.
How will the ovary be in that color, child? What are you telling? That is not the color of the ovary.
Ma'am, that is the ovary, ma'am, actually.
Sorry to interrupt, ma'am. It's time.
Okay.
Okay. Right. Thank you.
Thank you.
Dr. Madhuri, can you share your slide?
Yes. Yes. Is my presentation visible?
Yeah, your presentation has gone again.
I'm sorry, ma'am. Is my presentation visible now?
No. Your video also make it on, presentation and video both.
Yes, ma'am.
Yeah, now it is visible. Make your video on.
Yes.
No, here it's going.
It's
Yeah.
going again. Okay.
Yeah.
I'll just turn my video on and go back.
Yeah, now it is fine. Yeah, you can go ahead with presentation.
Ma'am, I'm Dr. Madhuri. I'm from Dr. B.R. Ambedkar Medical College. I'm presenting a case of bicornuate uterus with non-communicating left horn, complicated by the formation of hematometra, left endometriotic cyst, and bilateral hydrosalpinx. Introduction. The development of female genital tract is a complex process that depends on a series of events involving cellular differentiation, migration, fusion, and canalization. The Mullerian ducts form fallopian tubes, uterus, and proximal two-thirds of the vagina, while the urogenital sinus forms the distal one-third of the vagina and the urethra. Failure in any of the above process will result in congenital anomalies of the genital tract. Bicornuate uterus forms due to lateral fusion defect. The new ASRM Mullerian anomaly classification has descriptive classification, and the anomaly seen in our patient can be classified as a complex anomaly having bicornuate uterus with non-communicating left horn. Our case was a 34-year-old multipara that came with a history of pain in the abdomen since 6 months. That was of mild intensity and cyclical in nature. She also complained of abdominal bloating sensation during her cycles. She had undergone 2 lower segment cesarean deliveries. Both pregnancies were conceived spontaneously and reached full term. Her bicornuate uterus was first diagnosed in the early pregnancy scan done for the first pregnancy itself. This time when she presented to us with pain abdomen, USG showed bicornuate uterus with a hematometra of 8 cc in the left horn, and it also showed a left ovarian endometriotic cyst of 4.5 to 3.5 centimeters and bilateral hydrosalpinx. Intraoperatively, we found a bicornuate uterus with multiple endometriotic spots. The left ovary with the cyst was adherent to the left fallopian tube, the sigmoid colon, and the lateral pelvic wall. The ureters were traced, and the right ureter was found to have an altered course. It traveled medially, crossing the right uterosacral ligament, and was buried under the cervix. The non-communicating horn was resected laparoscopically, which was followed by left agnexectomy and right salpingectomy. Bicornuate uterus is 0.4% prevalent in the general population. Women with Mullerian anomalies are at higher risk for adverse pregnancy outcomes like euploid miscarriages, preterm deliveries or PPROM, small for gestational age infants, and malpresentation. Our patient, however, conceived spontaneously, did not have any miscarriages, and both pregnancies resulted in full-term cesarean deliveries that were extracted by vertex. Obstructive Mullerian anomalies are often associated with endometriosis, as seen in our case. To conclude, Mullerian anomalies like bicornuate uterus, which have high risk of adverse obstetric outcomes, can also have a completely normal course and outcome. However, renal evaluation for anatomical variations are necessary to identify the associated abnormalities.
Yes, thank you, Dr. Madhuri. So your patient is a 30-period multipara, but why did she develop hematometra after when is the last childbirth?
Ma'am, last childbirth, ma'am, it was 12 years, ma'am. 12 years back.
12 years back. Why
Yes.
suddenly she developed hematometra? Because mostly that means it will be inactive endometrium like that. That
Yes,
other why suddenly she has developed hematometra after 12 years, like 34 years. It's a bicornuate uterus, it was there.
Yes, ma'am. Bicornuate was there since before, but she did not have it was not diagnosed to be a non-communicating horn before. So maybe adhesions were formed later after the lower segment cesarean section, or during the section they might have drained the hematometra along with it, was what we thought. But she did not give any history of similar complaints.
No, but patient she has done her cesarean section done 12 years back. So now
Yes.
for almost 12 years she was fine, and for last 6 months she developed hematometra. What is the cause of suddenly developing hematometra when it is already non-communicating horn? Should have developed initially itself.
Yes, ma'am. Yes, ma'am. She should have, and ma'am. We only have theories, we can only theorize that it might have drained, and or maybe she's not giving proper history. But she only gave us history of 6 months of pain. That's it, ma'am. Previously, she was normal. She didn't have any issues before this, ma'am.
Yeah, because it is unlikely the patient is having a non-communicative horn with active endometrium and she will present with hematometra after 34 years.
Yes.
She would have presented earlier, even when she attended menarche. After
Yes,
that, she would have presented. Yeah. Okay,
Yes,
thank
ma'am.
you. Thank you.
Thank you, ma'am.
Thank you, Dr. Madhuri. Dr. Mangali Leelavati, can you kindly share your PPT? Dr. Mangali Leelavati.
Ma'am, she's not there here.
Move on to next. Dr. Manju Priya.
No, Dr. Mingala.
Dr. Manju Priya.
Manju is there. Dr. Manju is there.
Dr. Manju Priya, kindly share it. Dr. Mangali Leelavati.
Madam, good morning, madam.
Yeah, good morning.
Dr. Manju Priya.
Dr. Deepika.
Deepika is there. Deepika Gandhi.
Yeah, Deepika, can you share your PPT, please?
Okay.
So Deepika, please video on your please video on. Please share your screen, Dr. Deepika.
Yes, sir. Yes, sir.
First, open your presentation in the desktop. Go to Zoom and share screen. Select your presentation. Dr. Deepika.
Yes, sir.
What happened?
Sir, I am not able to share my video, sir.
Your video is visible. Your screen also sharing now.
Send my presentation in chat box, sir. Shall I open it?
No, your bandwidth is very low, Dr. Deepika. Rajni came and started a screen sharing. Who is this? Ma'am, we will call next presenter, ma'am.
Yeah, no problem, because they are taking some time.
Manju, can you share your PPT? Dr. Manju Priya.
Ma'am, can you hear me, ma'am?
Yeah, your video is seen. Please share your slide.
Yes, ma'am, sharing, ma'am.
Yeah, open your presentation first and come to Zoom and click that share screen green button and select your presentation and make it slideshow. It's very simple.
Manju Priya, share your PPT, please.
Ma'am, yes, ma'am, sharing, ma'am.
What is your problem, Dr. Manju Priya?
Ma'am, can you hear me, sir?
Yeah, please.
Can you hear me, sir?
Yes, please.
Sharing me. Can you hear me, sir? I'll share my
Yes.
PPT, sir. One second, sir.
Your video is visible. You are not sharing your screen.
One second, sir. I'm sharing, sir.
See, doctor, please carefully listen. You have to open your presentation first in your system.
It's already open, sir.
Come to Zoom and share screen. And the bottom on the Zoom, there is a share screen button is there now.
Yes, sir.
You click that. It will direct it to your desktop. The select your PPT, open PPT. Ma'am, next presentation, please, ma'am.
Yeah, you can go for the next. I think we should tell them to keep it ready.
Dr. Mangalya, can you start your PPT?
Madam, sharing, madam.
Please share.
See, if you will not be able to share the screen, just put it in the share chat box. I will download it and share it. Kinda untundi share option kinda.
Dr. Deepika, can you share it? Dr. Deepika?
Ma'am, I have shared my presentation in chat box, ma'am.
So can you share it, sir? Dr. Deepika's PPT, sir.
1 minute, I'm just downloading.
Sir, I'm Dr. Leelavati, sir. I shared my PPT, sir.
That's okay. అమ్మా ఓ సీత తీసుకొని వెళ్తా
So kindly can you make it fast, sir? Session is going to end.
I'm just opening, ma'am. Did you visible my screen? Hello?
Yes, sir. Yes, sir.
Yeah, please go ahead.
Sir, she is not in the session, sir.
Yeah, this is not there.
Sir, Manju, Deepika and Mangal Leelavati. These 3 slides only in this session, sir.
But she send it to your Meghala, send it.
No, that is not there in this session. Last is that Manju Priya.
They're sharing, but they're not giving access. What I have to do, ma'am? They're sending in a Google Drive. Simple format, there is no access.
Deepika?
Yes, ma'am. Am I audible, ma'am?
Yeah, your voice is breaking. You are not visible. Your slide is also not visible. Yeah, Deepika is visible. Yeah. You share your slide, Deepika.
Ma'am, I have shared my presentation in chat box, ma'am.
I need your access.
Sir, can you please send me online, sir?
Did you my screen? Hello?
Sir.
Leelavati.
Yeah, now it is visible.
Hello, sir.
Yeah, Dr. Leelavati can present. Your slide is visible.
Unmute yourself and start presenting.
Hello.
Yeah, you can present.
Good afternoon, everyone. I'm Dr. M. Leelavati, second year postgraduate from SP Medical College, Tirupati. Today, I'm going to present you a rare case of adenomyosis in a 26-year-old nulliparous. Introduction. Adenomyosis is a benign condition of the uterus defined by the presence of endometrial glands and stroma more than 2.5 mm in depth in the myometrium and a variable degree of adjacent myometrial hyperplasia causing globular and cystic enlargement of the myometrium, with some cysts filled with extravasated hemolyzed RBCs and siderophages. Rarely, adenomyosis may present as a cystic lesion with some cysts filled with lined with endometrial tissue surrounded by myometrial tissue when it is called cystic adenomyoma. Juvenile cystic adenomyosis is a subgroup of cystic adenomyoma that commonly occurs in adolescents or women less than 30 years of age, and it is not associated with diffuse adenomyosis. Today, I'm going to present an 26-year-old nulliparous woman who presented with history of severe and worsening dysmenorrhea since 6 years. She has attained her menarche at 16 years of age. From 6 years, she is having dysmenorrhea, but her cycles were regular with excessive bleeding. These symptoms were insufficiently relieved by NSAIDs and combined OC She never had a history of trauma or abortion or surgery. Transabdominal sonogram demonstrated a uterus of normal size. Myometrial echoes appeared normal. There were no focal lesions in the myometrium. Right ovary is normal, but in the left ovary, left ovary is bulky with organized echogenic contents with thin septa and cystic components peripherally measuring 4.5 into 3.8 centimeters. No evidence of calcifications or increased vascularity. Query hemorrhagic cyst. So we were unable to come to a diagnosis. So we advised her an MRI, which demonstrated mild bulky uterus with hypointense lesion in the left anterolateral wall, showing internal cystic areas, likely subserosal fibroid with internal cystic degeneration, query intrauterine cystic adenomyosis. Laparoscopic myomectomy and right ovarian cystectomy was done, and the specimen was sent for HPE. HPE revealed proliferation of benign smooth muscles in whorls, fascicles, stroma showing foci of endometrial glands and stroma, along with few congested vessels, and areas of hyaline degeneration was seen, which is suggestive of adenomyosis. After surgery, there is significant improvement in dysmenorrhea in the patient. Conclusion: this case draws attention to little known but not uncommon cause for both primary and secondary dysmenorrhea, which can affect young nulliparous women. MRI may be useful in establishing a diagnosis even when TVS and TAS is normal. In this population, fertility preservation is the primary goal, and therefore initial therapy for focal adenomyosis involves hormone suppression with combined OC pills. Further research is needed due to limited reports in the literature. Thank you, ma'am.
Yeah, thank you, Dr. Lilavati. Yeah, why you stopped this slide?
I didn't stop, ma'am.
Okay, I'll share it, ma'am. I only stopped it.
Just be there for 1 or 2 minutes.
Yeah.
Yeah. So nowadays, young patients, we are seeing more of the cystic like adenomyosis. So cystic adenomyosis, you did a myomectomy. It should be adenomyomectomy, isn't it?
Yes, ma'am.
Yeah. So like, what is the indication of surgery in a cystic adenomyosis? I'm not telling in your patient.
Yes, ma'am.
You
Cystic
go for a medical
adenomyosis.
management, or will directly go for a surgery in a young patient?
Young patient, in a young patient, we usually want to preserve her fertility, ma'am. That's why we'll go for medical management initially, ma'am. Like NSAIDs, OC pills, GnRH analogs, we'll prescribe this, ma'am. If she is relieved with that, we will not go for surgery, ma'am.
Yeah, it is not fertility. We are just removing the focal adenomyotic lesion. We are not going to do a hysterectomy or any ovarian pathology we are removing, isn't it?
Yes,
so
ma'am.
patient is not, yeah. So any like young nulliparous unmarried lady presented with dysmenorrhea, because this patient was not diagnosed before.
No, ma'am. Patient was not diagnosed before, ma'am. This is the first. From 6 years she came now, ma'am.
Okay, from like here in your college, you have diagnosed as a cystic adenoma. She has not done any scan also before, any ultrasound before, because she is having so severe dysmenorrhea.
No, ma'am. No, ma'am. She is suffering from dysmenorrhea, ma'am, but she didn't went to any hospital or she didn't have any investigations prior, ma'am.
Yeah. So in a young patient, always you should keep in mind the cystic masses. It is a newer varieties of like type of cystic adenomyotic lesions you are seeing in a particularly in a young adolescent girl or an unmarried girl. So you have to keep in mind when such patients are presenting with a severe dysmenorrhea. So you have to keep this diagnosis as a differential. What could be the differential diagnosis in your patient?
Sorry to disturb. Time up, ma'am.
Any other differential diagnosis?
It can be a leiomyoma or endometriosis, ma'am. But in leiomyoma and endometriosis, there won't be triple dysmenorrhea, ma'am. This patient is classically having triple dysmenorrhea, ma'am.
Yeah, leiomyoma with degeneration patient can have.
Yes,
Because your fish checks you showed it is a cystic lesion. So it can be a myeloma with a degeneration, like with the degeneration also. Yeah.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Dr. Deepika, can you share your PPT?
Ma'am, I have shared my presentation in chat box, ma'am.
See, I need access for this file, Dr. Deepika.
Sir, now I have sent from another mobile, another system.
Meghana poster who sent.
Yes, sir. That's
Meghana is yours.
yes, sir. Second one, sir. Second.
Ramya Sravan is there.
Dr. Manjupriya.
Ma'am, I'm not able to share the screen, ma'am. Can you hear me, ma'am?
Kindly share it in the chat box.
I have a Ramya Sravani PPT, ma'am. Can I share it?
Yeah. She is there in this group. Like
No, next session, sir. No, sir, she is the next session, sir.
Yeah, Ramya is not in this session.
Only two more are left, ma'am. Dr. Deepika and Dr. Manjupriya.
Deepika.
Yeah,
sir.
Deepika, can you post again in the chat box, please?
Yes, sir. Yes, sir.
What happened to Manjupriya?
Ma'am, once again, ma'am.
It's taking a lot of time, Deepika. I don't know why.
Sir, I have shared. Sir.
Meghala who shared it.
Yeah, Deepika.
Yeah, Sriman, make it a bigger size.
Yes, sir.
Yeah, present Dr. Deepika.
Oh, shall I start, ma'am?
Yeah.
Am I audible, ma'am?
Yeah, your voice is echoing, otherwise you are audible.
Another device.
Okay. Good morning, ma'am. I am Dr. Deepika, second year junior resident from Kanyakumari Government Medical College. My topic is on acute myeloblastic leukemia in pregnancy. Acute myeloblastic leukemia is a tumor of hematopoietic progenitor leading to accumulation of immature myeloid blast in the bone marrow. Eventually, this proliferation.
Lot of echoes are coming in your background. Like your voice is echoing. Can you do something with that?
Deepika, can you switch off another device which is on?
Okay. Shall I continue, ma'am?
Yeah.
Eventually, this proliferation spills into the blood. AML is about 4 times more common in adults than ALL. So the incidence of AML in pregnancy is 0.02%. 23 years old, second gravida, previous normal delivery women admitted in our ward with complaints of labor pain. She had no significant past history. She was booked an immunized case and on regular antenatal visits till the date. On admission, the patient was found to be dyspneic tachypneic, severe pallor present, generalized lymphadenopathy present, sternal bone tenderness present, CVS RS no abnormality detected. Perabdomen corresponds to term gestation, and by the evening itself, she delivered a term alive girl baby of weight 2.9 kg. On admission, her HB was 4 grams. Total leukocyte count found to be 5,000 and platelet count 27,000. Coagulation profile, renal function test, liver function tests are within normal limits. ECG, echo, and TFT are normal. Complete hemogram tracking was done. Everything found to be normal in her previous antenatal visit. Now patient presented with pancytopenia within a short span of 1 month, and her peripheral smear shows normochromic anemia and blast cells with RRs and severe thrombocytopenia. Bone marrow biopsy shows hypercellularity with 30% blast cells. Cytochemical staining was done, and it is positive for acute myeloblastic leukemia. And we have treated her with daunorubicin and cytarabine, and complete remission was obtained. Supportive management was done. Anemia was corrected by red cell transfusion, and thrombocytopenia controlled by platelet transfusion. Sepsis treated with higher antibiotics. I'm going to discussion. So the AML is about AML reported in 1 out of 75,000 to 1 lakh pregnancy. Common age presentation is between 15 to 40 years. Clinical findings are splenomegaly, hepatomegaly, bony tenderness, gum hypertrophy. And lab findings shows predominant myeloplastic peripheral smear. Bone marrow study shows hypercellularity with more than 20% blast cells. AML is usually associated with genetic aberrations. The most common...
It's time for discussion, ma'am.
Yeah. So, Dr. Deepika, this is a case report, isn't it?
Yes, ma'am.
Yeah. Then why did you make it as a aims, objective, materials, and methods? This is a very basic, no? In a case report, there is no aim, objective, and materials and methods. It will be just introduction, case report, discussion, and then conclusion and your reference. Okay, so these basic things you should follow it. Next thing, you told this patient is a booked case in your hospital?
She's booked case in a PHC, ma'am.
But she was a booked case in a PHC. But
Yes,
when she came to you, that time you diagnosed this patient is having AML, isn't it?
Yes, ma'am. Yes, ma'am.
Okay, she was not diagnosed before.
No, ma'am, not sure. She was found to be normal in her previous antenatal visits, ma'am, with HB10. After 1 month, she was referred here for sudden HB fall around 4 grams in the PHC. That's what she was referred here, and we delivered her, and we diagnosed to have acute myeloblastic leukemia.
So that is post-delivery it was diagnosed.
At the admission, the HB was 4. So we treated her with the Paxil and platelets. Peripheral smear report come by next day only. Then only we found that it was a case of acute myeloblastic leukemia, and we do bone marrow biopsy and evaluated and found out that.
All this bone marrow biopsy, everything was done in the postpartum period, isn't it?
Yes, ma'am.
Yeah. And suppose this patient you would have diagnosed having AML because he is already having anemia. Maybe in the 2nd trimester, what you would have done for this patient?
Ma'am?
Suppose this patient you would have diagnosed AML in the 2nd trimester. Same patient. Now you have diagnosed in the postpartum period. For you, it is easy to manage the patient to start the chemotherapeutic drugs, isn't it? Suppose the same patient you would have diagnosed AML in the 2nd trimester. What you would have done? What is the plan of management if you are diagnosing in 2nd trimester?
If the case was diagnosed in 2nd trimester, the case study has told that in 2nd trimester and 3rd trimester, chemotherapy is comparatively safe. For the life of mother, we can use, ma'am, but the risk of having congenital anomalies like cardiomyopathies should be informed to the attenders, and we can continue the pregnancy. But if it is diagnosed in the 1st trimester, means we have to terminate the pregnancy.
Yeah. Okay. Okay, thank you. But next time, make sure when you're ready, you just follow the basic principle. Being a case report, you cannot write aim, objective, metals, methods, because in this your mark is becoming negative. You got my point?
Yes, ma'am.
Yeah. Thank you.
Thank you.
Dr. Manjupriya, can you share it now?
Yes, ma'am. I'll share with you.
Call பண்ணாங்க அவங்க தான கால் பண்ணாங்க.
I think this is the last presentation, Manjupriya.
Okay, can you see the screen, ma'am?
Yeah, just make it like a full screen because it is only. No, you are not. Make it a bigger one. I think you are presenting from home.
Yes, ma'am. My laptop is not big, ma'am. Shall I start, ma'am?
Yeah, you start.
Good morning, ma'am. I'm Dr. Manjupriya from Tanjore Medical College. I'm here to present a case of acute abdominal 1st trimester a rare case of superior mesenteric vein thrombosis. Introduction: mesenteric vein thrombosis is an infrequent thrombotic event that can cause devastating intestinal ischemia. The mortality rate among the patients with acute mesenteric vein thrombosis ranges from 20 to 50%. Occurrence of mesenteric vein thrombosis in pregnancy is a very rare, quite rare. A wide range of prothrombotic states that have been linked with mesenteric vein thrombosis, including cancer, trauma, post-operative state, as well as in vitro fertilization. Mainly, it is embryo transfer and cirrhosis of liver and portal hypertension and deficiency of protein C, protein S, and antithrombin 3 deficiency. A case report which was seen was a 29 years old gravida 4 para 2 live 1 E1 with previous normal and previous 1 LSEs with 2 months of amenorrhea. She was a known case of chronic hypertension and over diabetes on insulin. She was received in our emergency department in the intubated state. Patient had history of bleeding per vaginum, 1 episode, and patient became collapsed after that. Past history, patient had history of severe epigastric for 1 week, which was evaluated and conservatively managed. Patient was unconscious with tachycardia and distended abdomen, and the abdomen was rigid. Patient was in view of suspected rupture ectopic pregnancy and others are suspecting acute surgical condition. Patient was taken up for emergency laparotomy along with a surgical gastroenterologist. Intraoperatively, there was a serosanguinous turbid fluid of about 1 liter, and uterus, both ovaries and fallopian tubes was found to be normal. Small bowel was found to be gangrenous from the duodenojejunal flexure to 70 centimeter of the 70 centimeter. Proceeded to resection and feeding gynecostomy was placed, ma'am. Post-operatively, patient was was given adequate IV fluid later with iron supports. The patient could not be survived, ma'am. Discussion: mesenteric vein thrombosis is extremely dangerous. It is characterized by an insidious onset and early non-specific clinical presentation, but can progress very rapidly. Patients with mesenteric vein thrombosis may die after a remarkably short time course due to sepsis, multi-organ failure, and shock. In summary, mesenteric vein thrombosis in pregnancy is a rare yet important cause of intestinal ischemia. Non-characteristic symptoms, signs, and laboratory results lead to incorrect or late diagnosis of mesenteric vein thrombosis. When a pregnant patient presents with an acute abdomen, especially when symptoms are out of proportion to the signs, mesenteric vein thrombosis could be included in the different diagnosis.
You mentioned other complications.
Ma'am, can
Yeah.
Yes, ma'am.
Yeah. So your patient, when she had pain, like after how many days of pain she was referred to you?
Ma'am, patient had history of bleeding episode in her home, ma'am. She was taken up for a private hospital where she was evaluated and she was connected and referred to our hospital, ma'am.
That was how many days before? Because you, like, a patient could not be saved. That's what I just wanted to know. How many days before she had pain?
She had pain 1 week back, ma'am. Hyperemesis with pain abdomen, epigastric pain, ma'am. She was taken to private hospital conservatively. Like she was given.
Can you tell me some differential diagnosis of acute pain abdomen in pregnancy?
It could be a rupture uterus ectopic pregnancy, ma'am.
Yeah, in ectopic patient doesn't have a so severe a pain abdomen. There will be a pain. She had acute abdominal pain. Anything else?
Rupture uterus, ma'am. Can suspect rupture uterus.
She is a first trimester, no?
Yes, ma'am. Appendicitis, ma'am.
Yes. Anything else? See, when patient is coming acute pain abdomen, you should have lot of differential diagnosis in your mind, isn't it?
Okay, ma'am.
Yeah, and that too, you know, it is like superior, like this mesenteric vein thrombosis. It is rare. It is not a very common thing.
Yes, ma'am.
So it can be acute pancreatitis also, isn't it?
Acute cholecystitis also.
Yeah, acute pancreatitis, very severe acute abdominal pain. It happens mostly in acute pancreatitis and in the superior mesenteric vein thrombosis. How can you diagnose antenatally? This patient already she has a gangrene. Can you tell me some silent features of diagnosing superior mesenteric vein thrombosis, so that you can differentiate from the others?
Tachycardia, ma'am. Tachycardia and rigid abdomen.
Yeah, that is common features. Any patient with having acute pain abdomen, patient will have a tachycardia. See, mostly this patient, they will present with a high total leukocyte count, but without any evidence of peritonitis. Got my point? Already
Yes,
this
ma'am.
patient had a already gangrenous abdomen, everything, and there patient will present with a late presentation. In earlier, suppose she would have come to you maybe in the earlier, like 1 week before, maybe you would have saved the patient, isn't it?
Yes, ma'am.
Yeah, and that too you can go for a just Doppler, ultrasound Doppler to know wherever there is a thrombus. And suppose you are diagnosing early, there is no evidence of any gangrenous bowel. How will you manage the case?
We're looking for any other pathology, ma'am.
No, if
Actually,
you are diagnosed, it is a superior mesenteric vein thrombosis. How are you going to manage? There is no gangrene bowel.
we can start on anticoagulants, ma'am.
You can give a unfractionated heparin. Okay.
Anticoagulants and antibiotics conservative management, ma'am.
Thank you.
Yes, thank you, ma'am.
Thank you, ma'am. The session has got over, ma'am. Thank you, Judge. The next session is going
Thank you so much.
We'll start with Dr. Mehala MP. We'll just Thank you, judges, for judging the first two sessions. Thank you, ma'am.
Thank you.
We'll invite Dr. Shyamala and Dr. Veena for the next session, ma'am. Welcome, ma'am.
Hi, Veena.
Finished your session. How many you finished?
I finished 13. You're supposed to be 18, but 13 we finished.
I have 19. I don't know how many of them are present over there. Let's see. I'll finish up. Bye-bye.
Okay, bye.
Welcome, ma'am. Dr. Mehala.
Yes, ma'am.
Share your PPT and start presenting. Dr. Mehala.
Yes, ma'am.
Share your PPT, ma'am.
Good morning, Dr. Veena. I'm Dr. Shyamala here.
Shyamala, hi.
Hi.
SRMC, yeah?
Yeah. I'm from SRMC.
Hi, ma'am.
Dr. Magla, you can.
Yes, ma'am. Hello?
Yeah.
Ma'am, is it visible, ma'am?
Yeah. Nice.
It's shared, ma'am.
Can you enlarge it a little bit?
Hello?
Go on, ma, go on.
Oh. Shall I present, ma'am?
Start.
Good afternoon, ma'am. This is Dr. Mehala, second year OG-PG from Kanyakumari Government Medical College. Today I am going to present a case of AV malformation, a rare cause of secondary PPH. Introduction. Uterine arteriovenous malformation is a rare but potentially a life-threatening cause of postpartum hemorrhage. It is defined as an abnormal vascular connection between the uterine arterial and the venous system. It can be either congenital or acquired. Congenital arterial AV malformation is due to failure of differentiation, vascular differentiation during the fetal agenesis. The acquired arteriovenous malformation is the most common, and it can result from prior uterine surgeries like prior cesarean section, DNC, or any infection or malignancy. Aims and objective. The aim of the study is to delineate the rare cause of secondary PPH, clinical presentation, management, and successful outcome in a tertiary center. Case report. A 20-year-old primary gravida with low risk pregnancy presented with spontaneous onset of labor at a gestational age of 39 weeks and 2 days. Her labor progressed normally. She had an arrest of descent at the second stage of labor, and we underwent a primary C-section for her. She was discharged on post-operative day 6 in a stable condition. On POD 15, she presented with heavy bleeding per vagina. On admission, she was hemodynamically stable with her hemoglobin of 8.9
and her BP was 120/80. She was transfused 2 units of packed cell in suspicious of RPOC. Hence, transvaginal ultrasound was done, which shows hyperechoic vascular lesion with multidirectional flow present in a posterior myometrial junction, highly suspicious of AV malformation. To confirm AV malformation, we took MRI. The MRI shows persistent, prominent myometrial vessels in the posterior myometrial junction. This is the UHN MRI picture showing AV malformation. The treatment is decided after considering the patient age, degree of bleeding, hemodynamic instability, and the desire for future fertility. My case, she is a para-1 live one, and she wants next pregnancy, and she is hemodynamically stable. So we taken up her for uterine artery embolization. Angiography done. It confirmed the presence of AV malformation, and the uterine vessels feed that AV malformation. Selective embolization of uterine artery has been done by using polyethylene glycol. The procedure was successful with post-operatively no visible flow seen in the atriovenous malformation zone after embolization. Post-op period was uneventful, and the patient was discharged on post-operative day 7 without no complication. After that, patient had no bleeding or no any other complaints. Discussion: AV malformation is the rare cause of secondary PPH. In initial days, it is diagnosed only after the histopathological examination of specimen after an hysterectomy. Now, because of recent advanced technique like UHG and MRI, we diagnose an AV malformation in an early state and we manage her without proceeding hysterectomy. Conclusion: this case report highlights the cause of secondary PPH. Although it's a rare entity, clinician should aware of it, and early identification and proper treatment will save the patient.
Discussion. It's time for discussion, Dr. Meghla.
Yes, ma'am.
So, Dr. Meghla, when you said that is TVS, you found out the TVS findings, you said you make it out. What is the diagnostic finding you make it out in TVS?
Ma'am, there is an hypervascular area with bidirectional flow.
What else you see in this TVS?
Ma'am, whether any retained products is there or not.
Okay. Now, to confirm the AV malformation, you have to say the peak systolic velocity.
Peak systolic velocity index, ma'am.
So, what is the gold standard for AV malformation? Gold standard test for AV malformation?
Angiography, ma'am. Pelvic angiography is a gold standard test. To know the feeding vessel.
Dr. Meghla, you are suspected.
Yes, ma'am. Hello, ma'am.
Can you hear me, Dr. Meghla?
Yes, ma'am.
When you suspected it is a AV malformation by TVS itself, why a MRI pelvis was done?
To confirm the diagnosis.
No, is it the investigation of choice?
No, ma'am. No, ma'am. Pelvic angiography is an investigation of choice, ma'am. It's a gold standard diagnosis.
What would be a differential diagnosis at that point of time? Differential diagnosis.
Differential diagnosis may be RPOC, ma'am. Retained product of consumption will also show in vascular area.
What else?
In a gynec patient, adenomyosis also present like that.
Talk about your patient. Talk about
yes, ma'am. Retained product of consumption. RPOC might be the differential diagnosis, ma'am.
Sorry to interrupt, ma'am. It's time up, ma'am.
Hello.
What would you have done if there is no facility for uterine artery embolization?
Ma'am, we go for laparoscopic guided uterine artery ligation, ma'am.
Okay.
Yes, ma'am.
Okay.
Thank you, ma'am.
So next student can present.
Dr. Meghna Rao.
Yes, ma'am.
Can you share your PPT?
Yes, ma'am, sure.
ஆக்சுவலா வந்துட்டு அவ பிரசன்ட் பண்ணி முடிக்கிறதுக்கு டைம் வரும். இந்த ரெண்டே क्वेश्चन தான் கேட்டாங்க. வாட் லைக் தி டிஃபரன்ஸ் கேட்டாங்க. ரிட்டைன் ப்ராடக்ட் ஆஃப் கன்சம்ப்ஷன்.
Share your PPT.
ரெகோல்யூஷன் ஃபெசிலிட்டி இல்லனா என்ன?
I did, ma'am.
லாப்ரோஸ்கோபிக் கைடட் லைசேஷன் ஆஃப் யூட்ரஸ். ஓகே டைம் சரி நாளைக்கு இப்போ எனக்கு ஓபன் பண்ணிட்டாங்க.
Is that visible, ma'am?
இது நம்ம வெளிய வந்துடலாம் ஃபர்ஸ்ட்.
Yes, it's Meghna.
Good morning, ma'am.
Start presenting, Meghna.
Good morning, ma'am. I'm here to present a case of undiagnosed fetus papricious in twin pregnancy, ma'am. Introduction. Excuse me, ma'am. Introduction. Fetus papricious is a rare condition where one of the fetuses is compressed, mummified, takes parchment-like state attached to the placenta. It can be seen in both monozygotic and dizygotic twins, but most common in monozygotic. Incidence of fetus papricious ranges from 1 in 184 to 1 in 200 in twin pregnancies, in 1 in 12,000 in live births. A case report, I'm reporting the case. A 24-year-old primate with 36 weeks of gestation came to Obs and Gynae OPD of our hospital with a complaint of abdominal tightenings in 6 hours. She was admitted for safe confinement. On examination, per abdomen uterus corresponds to 34 weeks of gestation. Moderate contractions, that is 2 to 3 contractions for 25 to 30 seconds in 10 minutes. Its cephalic presentation on ROA, FHS is 135 to 140 beats per minute. On pervaginal examination, cervix was 50% effaced or 3 centimeters dilated. Presenting part is vertex at -2 station. Bag of membranes is forming. Pelvis is gynecoid and adequate. Another hard mass of about 5 to 5 centimeters, which is shell-like in consistency, is palpable through the lower lip of the cervix, which is extending upward, but the upper border of the mass could not be reached. Delivery details. Twin A fetus papricious presented at +2 station, which was delivered out manually by controlled contraction in toto along with the cord. A tiny bit of placenta was expelled on its own. Twin B is presented with vertex at +1 station. ARM was done and a liquor is meconium stain. RMLE given a live baby of 2.8 kg delivered vaginally. The twin B has a single umbilical artery. Discussion. Intrauterine death of one twin may be due to twin-to-twin transmission syndrome, placental insufficiency, congenital anomalies. The prognosis of the surviving twin in the case of fetal demise of co-twin depends on the factors such as gestational period of at the time of death, period between the fetal demise and delivery of the surviving fetus, number of fetuses, chorionicity, and the cause of death of the fetus. Conclusion. The primary concern of fetus papricious is its effect on the surviving fetus and the mother. To avoid complications, serial ultrasound examination is mandatory. In our case, the dead product of conception were retained in the uterine cavity for months. Fetus has took parchment-like appearance due to mechanical compression over the uterine wall and did not induce any complications for the mother and a growing fetus. Thank you.
So, Meghna, was it a booked case or unbooked case?
Unbooked case, ma'am.
You have to mention in that because unbooked case will have a surprises like this.
Yes, ma'am.
She had any scans in the first trimester, second trimester?
Ma'am, she had a scan at 32 weeks, ma'am, which was given single live fetus, ma'am. Only single scan, that is also not a printed scan, ma'am. Written bedside scan, ma'am.
So no first trimester scan was done with this patient?
No, ma'am. No, ma'am.
Gestation or dichorionic gestation?
Ma'am, it was diamnotic dichorionic, ma'am.
So do you expect any kind of problems on surviving twin in dichorionic gestations?
Ma'am, no, ma'am. Usually in monochorionic and monozygotic, the surviving if the fetus papricious, the surviving fetus will have effect, ma'am. In dichorionic, it is less chances to affect the surviving fetus, ma'am.
What gestation you think this fetus had expired?
I think, if you think it is 16 to 18 weeks, ma'am.
Probably. Right, but that just it's not going to have much effect on the surviving twin.
Yes, ma'am.
Okay.
Thank you, ma'am.
Thank you, ma'am. Dr. Mirumya Devi, can you present? Can you start your PPT?
Hello, ma'am. Good morning. Can you hear me, ma'am? Hello. Hello.
Yeah, start presenting.
Yes, ma'am. Good morning, ma'am. This is Dr. Mirunmay Devi, pursuing my second year DNB from South Central Railway Hospital, Secunderabad. I'm presenting case on endometrioma, which was mimicking as a huge abdominopelvic mass, mimicking neoplasm. Endometriosis, as we know, it's gynecological benign disease, which is hormone-dependent chronic inflammatory condition, mainly seen during the reproductive age group. They have various clinical features ranging from vague pelvic pain towards subfertility and fertility. But this case I selected because of its rare entity of symptoms presenting as a sudden onset of symptoms, mimicking a neoplasm. It belongs to class 4 of early onset anemia, according to American Society of Reproductive Medicine. Here comes the case report. 25 years old unmarried girl admitted in our institute with the complaints of abdominal pain for past 2 months, which was spasmodic in nature, starting couple of days before the menses and release after menstruation and with medications. And she also complains of just abdominal distension for past 1 month, vague abdomen. Incidence in onset, progressive in nature, which attained to the present size. No history suggestive of constitutional symptoms or hyperestrogenism or hyperandrogenism. Her cycles were attained menarche in 15 years of age. Menstrual cycles were regular, having 3 to 5 days for every 26-day cycle with moderate flow, using 2 to 3 pads with dysmenorrhea present for past 2 months. On examination, patient is thin built with vitals within normal limit. Lower abdomen is uniformly distended with umbilical slightly pushed above. On palpation, there is a mass corresponding to 24 weeks with smooth surface, firm in consistency, with sidewise mobility present, and lower borders cannot be made out, revealing it to be a pelvic origin with dull on percussion, no auscultating findings between this vascular, nothing is found. Since she is unmarried, we didn't do per speculum or per vaginal bimanual examination. Per rectal examination revealed no nodularity. On ultrasound, she was admitted and subjected for further investigation. Ultrasound pelvis revealed uterine size of 67 into 53 into 12 mm with ET of 10 mm and large 161 into 135 mm complex cyst having dense echoes in the right adnexa with similar 36 into 32 mm in the left ovary, the left adnexa, as noted. And radiologist advised for further investigations with CECT abdomen and pelvis, which revealed a large abdominopelvic thick walled complex cyst of 11 into 17 into 12 centimeters with thick internal septations with fluid, ill-defined peripheral solid components in the midline arising from the right adnexa with compression of the right lower ureter. And there is also left simple ovarian cyst of 3.3 into 2.6 centimeters with minimal ascites. Ileocholic lymphadenopathy present with minimal omental stranding and thickening. Right moderate hydronephrosis in view of compression over the mid proximal ureter. Tumor markers, she was subjected to tumor markers, which was CA 124, 52.5, which is slightly elevated with other tumor markers under normal limits. Patient was taken up for exploratory laparotomy. With intraoperative findings, we can find a large cyst of 13 to 20 centimeters, which is arising from adnexa, containing around 2 liters of chocolate colored fluid.
It's time for discussion, ma'am.
Okay.
So was it a laparotomy or a laparoscopy you planned?
No, ma'am, laparotomy, because we were not confirmed. Before taking up for surgery, we were not confirmed whether it's endometriosis or some other malignant pathology.
No, you can do a diagnostic laparoscopy because all the tumor markers are normal and you did an MRI also that is suggestive of ovarian mass.
Yes, ma'am, but it is thick internal septations with solid component and with minimal ascites that gave us suspicious. So we don't want it. We went for a laparotomy, ma'am.
That is acceptable, absolutely, because you had a doubt about it being malignant. That is fine, yes, but clinically you couldn't suspect endometriosis at all?
Ma'am, clinically by symptom wise, actually we can have it. That's why we had a DD kind of thing.
Yeah, there is no dysmenorrhea. She had dysmenorrhea.
Dysmenorrhea. Right? She had dysmenorrhea. That's what it was a DD kind because of
any tenderness.
Sorry, no, ma'am, no tenderness.
Because a young unmarried girl and abdominal incision should have been avoided at any cost, right?
Yeah, yes, ma'am.
In that scenario, you can just put in a scope and see without touching.
Okay, diagnostic laparoscopy kind of thing.
That would have been better for the girl, like young girl. Now she has to have a big incision.
What kind? Vertical or transverse you get?
Transverse, ma'am.
Transverse.
Yes, ma'am. Like section.
What kind of staging will you do with trans when you have suspicious mass, man? No?
Sorry, ma'am.
How can you do a staging laparotomy if you think it is suspicious mass with a transverse incision? You can't. Anyway,
Yes, ma'am. Yeah, it's like clinically it was like 90% like endometriosis, but in case if it's like it can be both therapeutic and diagnostic, and we had its transverse incision.
So
we
you have
took
a
for
90% confirm. You said you're 90%. You're thinking about endometriosis only, no?
Yes, ma'am. Yes, ma'am. And 10% we are like doubtful.
Sorry to interrupt, ma'am. It's time up, ma'am.
Okay.
Sorry.
Dr. Monica, can you share your PPT?
Yes, ma'am. Ma'am, is it visible?
Yeah.
Yeah. And this is Monica. I'm from Vaidhi Institute of Medical Sciences from Bangalore. I'm presenting a case report of cervical agenesis with functioning uterus. It is a successful surgery with Foley's catheter stent. So coming agenesis is 0.01% in general population. It represents about 3% of all the uterine anomalies. It is estimated that only 4.8% of women with cervical agenesis have a functioning uterus. Objective of the treatment is symptom relief, achievement of regular menstruation, and restoring fertility. In this case report, a simple method was used and proved effective. Case report, she was a 19 years old patient presented with primary amenorrhea with cyclical abdominal pain for the last 7 years. On examination, her secondary sexual characteristics were well developed with a blind vagina of 3 cm was noted. MRI was done. MRI showed normal size uterus with ET of 10 mm with bulky right of
Not audible.
Yes, ma'am.
Dr. Monica, you were not audible for a moment.
Okay. The MRI showed the normal size uterus with ET of 10 mm with bulky right ovary with hemorrhagic follicles, mild free fluid noted in the pelvic cavity and the POD. Cervix appeared hypoplastic with non-delineation of the cervical canal. It was an abdominal perineal approach. A number 16 Foley's catheter was used to create a uterovaginal tract. And the intra-op findings were there was hemoperitoneum of 250 ml, uterus was 12 week size, hematometra was noted, but it was not extending to the cervix. The cervix was found to be 3 cm cylindrical structure with no lumen. Neo-endocervical canal was created. Actually, intraoperatively, there was a hypoplastic cervix noted. And bilateral endometriotic cysts were noted of 2 into 2 centimeters each. Post-operatively, Foley's catheter was kept in situ for 3 cycles. Currently, the patient is having normal menstruation. Coming to the discussion. Once again. Coming to the discussion, the uterine cervix provides an outflow tract for the menstruation. Hysterectomy was eventually the treatment for cervical agenesis because of the common complication of recanalization of the cervix and the unlikelihood of the viable pregnancy. But the recent advances led to conservative surgery as a first-line treatment, as in this case. Conclusion, the procedure compromises to be a simple and reasonably effective method for the creation of a menstrual outflow tract for cases of cervical agenesis with functioning uterus. Hello, ma'am.
Dr. Monica?
Yes, ma'am.
Can you hear me?
Yes,
okay.
ma'am.
This patient in the MRI did not show any hematometra?
MRI did not show any hematometra, ma'am. Actually, initially we were also thinking the MRI it showed ET of 10 mm, but there was no hematometra. But there was free fluid noted in the POD. So what we thought was there was definitely a retrograde menstruation. That's why there was an hemoperitoneum of 250 ml. But she was not
And
menstruating.
Okay. Good case.
Yes.
Dr. Shamla?
Yeah. Did you use it kept for 3 months continuously, or you removed and you did it?
No, ma'am. It was kept for 3 months in situ continuously because we had taken a silicone Foley's catheter. So it had a good durability. That's why we had kept for 3 cycles. And she was having a successful menstruation with the tube in situ for 3 months. Then later we removed it and she had continued to have normal menstruation. She's still under our follow-up right now, ma'am.
Okay, post surgery, did you do any vaginoscopy or hysteroscopy?
Post surgery, actually her vaginal cavity was it was not very much obliterated. There was almost around 3 to 4 centimeter proper vaginal length was also like it was a blind vagina. But later on, once we had removed the Foley's catheter, it was not like a proper anatomy. But we could there was not a proper cervix visualized, but we could see a path. It was like that.
Sorry to interrupt, ma'am. It's time up, ma'am.
Yeah.
Okay, thank you.
Okay.
Dr. Nandini, can you share your slide? Dr. Nandini.
Moving on to next person. Dr. Neenavat. Dr. Neenavat.
Hello. Ji, ma'am. Good morning, ma'am.
Share your slide, please.
Yes. 1 second. Can you see it, ma'am?
No. No, Neenavat.
No.
Oh, I'm so sorry, ma'am. I'm unable to do this.
Moving on to next person, ma'am.
Yeah.
Dr. Nipasa, can you share your slide?
Yes, good morning, ma'am. I'm present. I'm sharing my screen. Ma'am, is it visible?
Yeah, go on.
Good morning, everyone. I'm Dr. Nipasa Sharma. I am a junior resident at Department of Ops and Gynecology in Kasturba Medical College, Manipal. My poster today is based on peripartum management of hemophilia B. Hemophilia B is an X-linked recessive disorder which is caused by deficiency of factor VIII. It is a rare entity with an incidence of 1 in 10,000 cases. The management of such cases need a tertiary care center with ops and hematologist team. Now this case, it is a 36 years old, gravida 3, para 2, living 2, known case of hemophilia B. She has no family history of bleeding disorders, no history of bleeding manifestations or heavy menstrual bleeding in childhood. Her ops history, first pregnancy was a full-term normal delivery at Government Hospital, Udupi. Postnatal day 5, she had PPH. She underwent multiple blood transfusion followed by bilateral internal artery ligation and utero-ovarian artery ligation and followed by ICU admissions for 7 days. Inter-pregnancy, she was diagnosed with factor VIII deficiency. Her second pregnancy was a full-term normal delivery at our hospital. She had PPH postnatally, which was managed conservatively. This pregnancy, again, natural conception. She's a booked case at Kasturba Hospital. Throughout her antenatal period, her general physical examination, OP examination, and routine antenatal investigations were normal. No history of APH. At 38 weeks, we had admitted her for safe confinement. The peripartum management, hematologist consultation was sought in view of hemophilia B. They had advised for TEG. TEG was done, which was within normal limits, and PT and APTT were monitored. They had advised her to be transfused with 8 units FFPs before labor and again repeat 4 FFPs after 12 hours. She was induced and she underwent induced vaginal delivery and delivered a male baby. Screening of bleeding disorders were done in the baby. Post-delivery, she had mild PPH, which was managed with oxytocin and methotrexate. Hematologist review was sought and she was transfused with 1 pint PRBC and 5 FFPs immediately after delivery. Repeat 5 units for transfuse on postnatal day 4 and she was discharged on postnatal day 6 in a stable condition. Now, bleeding disorders are usually a rare entity in pregnancy, and the female carriers are usually asymptomatic. They are prone for abnormal bleeding during antenatal period, during delivery, and also in postpartum period, associated with significant morbidity, blood loss, anemia, and some cases requiring blood transfusion. Management of such case hence requires a tertiary care center with relevant expertise with close ligation with hemophilia center. It is best to avoid invasive procedures and traumatic deliveries. Normal delivery is usually indicated in such cases, and adequate transfusion and blood products is required. The limitation of such cases, there is not much evidence for the use of prophylactic drugs in women with inherited bleeding disorders, and replacement of the defective factors usually the preferred approach. Thank you.
Okay, person. Hello.
Yes.
See, this patient almost had a near miss event in her first pregnancy. Right?
Yes, ma'am.
She
Yes,
was diagnosed with some problem. You had an objective diagnosis in between the pregnancies, and second delivery was in Manipal.
Yes, ma'am.
Right.
Second delivery was in
Why
Manipal.
was sterilization not offered to her after second delivery?
Ma'am, why was? Ma'am, we had advised her, but she didn't want to get it done. So usually we have.
I can't hear you.
Ma'am, can you hear me?
Yeah, now it's better.
Yes, ma'am. So after her second delivery, we have advised for sterilization because first was also her first delivery was also very severe, and after her second, we had advised for sterilization, but the patient deferred. So hence she got pregnant again, and that was also managed well, ma'am. After this delivery, she underwent interval sterilization.
Sorry to interrupt, ma'am. It's time up, ma'am.
Yeah, only one question from me. Was it sufficient one day only you transfused FFPs just prior to the induction? Will it be sufficient because she already had PPH in the second pregnancy?
Ma'am, because of that, we had taken the hematologist consultation, and according to them, 8 units one day before, and after 12 hours, 4 units more. So total of 2 days, like 12 hours apart, we transfuse FFPs. That was sufficient enough in this case, ma'am. Yes, ma'am.
Okay.
Thank you, ma'am.
Dr. Niranjana. Dr. Niranjana, can you share your slide?
Okay. The other participant is sharing. I'm not able to share now.
Can you stop sharing your slide? Dr. Nipasa, can you stop sharing?
Okay, ma'am. Can I start now? Can I start, ma'am?
Yeah, start present.
Good afternoon to all. I'm Dr. Niranjana. I'm doing my fellowship in endoscopic gynecology. And my case report is on a patient with bleeding after hysterectomy. So bleeding is a common complaint we encounter in gynecology OP, and patients feel that once they get surgery, hysterectomy, the bleeding complaint stops. But if this patient is going to start having a bleeding episode after her hysterectomy, the patient as well as the doctor, both of us are going to become anxious. So this is a case report of a patient who had bleeding after the surgery. So she's a 38-year-old unmarried, a sister who presented with a heavy menstrual bleeding for 1 year. For the past 4 years, she was diagnosed as a case of fibroid, but she was asymptomatic. But now when she presented with heavy menstrual bleeding, the uterus was corresponding to 16 weeks. The patient did not want a surgery, so she was opted for medical management. She was doing fine. But 2 years after the medical management, she again presented with profuse menorrhagia and dysmenorrhea, which was not settling. So now the patient was convinced that she'll proceed with the surgery. And so she was taken up for a total laparoscopic hysterectomy. Intraoperatively, the uterus was 20 weeks size. It was an uneventful surgery with a total blood loss of only 50 ml. And the patient was discharged on post-op day 3. So during the intraoperative, we can see that the vault has been clear and the hemostasis was fine. But 1 year after, even her follow-up visits were normal. But 1 year after the surgery, she again presented with complaints saying bleeding on and off. So we did the routine investigations of a total blood count, culture, ultrasound imaging, and everything were within normal limits and there was no obvious mass. So we reassured the patient, but still the bleeding episodes persisted. A vaginoscopy was done, which again revealed a normal vault. So we put her on antibiotics to treat any possible infection, and tranexamic acid and packing was done. But once the pack was removed, again she started having bleeding. And so to rule out any other cause, a pelvic angiogram was done, and we found aberrant vessels from the left-sided artery supplying the vault. So the embolization of these vessels was done to avoid any major surgery. And post-embolization, the patient was discharged and is being asymptomatic for the past 6 months. So the incidence of secondary hemorrhage after hysterectomy is 0.2 to 2%, and there are varied causes like slip ligatures, infection, hematoma, and tears. There have been reports saying that the collaterals can become functional anytime after ligation of the main trunk. And there's also another report that said uterine artery pseudoaneurysm was found on day 22 after lap hysterectomy and required embolization. So the purpose of this case report is that bleeding after hysterectomy is indeed a nightmare. But a stepwise approach to rule out possible causes like infection or a hematoma or a tear and vaginoscopy helped us to find the diagnosis of the aberrant vessel and treat her with a minimal invasive approach, thus improving her quality of life. So multidisciplinary approach and the stepwise treatment helps in treating the patient better. Thank you.
Dr. Niranjana?
Yes, ma'am.
Good case, well managed. See, all these DDs what you have given now,
yes,
the common causes of bleeding, they're all not so late. Now, after a year of hysterectomy, none of them will occur. Once you have abnormal bleeding coming after a year of hysterectomy, obviously look for something rare like this.
Yes.
It's very unlikely that it will be because of post-surgical, any kind of issues, right?
Yes, ma'am.
That was a good one.
Thank you.
So apart from, what are the other causes? Sometimes people present without any abnormal vascular, they do come with little bit cyclical bleeding.
Yes, ma'am. And sometimes if a rare case of vault granulation tissue can cause bleeding in very rare people, in some cases.
Any other conditions? They'll have spotting or random.
If the patient is developing any malignancy later on, or since the ovaries are retained, if she has went on to develop any ovarian malignancy that has led on to the condition, any ovarian malignancy can cause occasional spotting or vaginal granulation tissue, and some if there was any trauma to the patient also, that can also cause a tear in the vagina causing bleeding.
Okay.
Thank you.
Benign condition pursuing.
Okay.
Regular ovulations are because she is only 36 years. We did hysterectomy. The ovaries are retained. But this lady had heavy bleeding. You had a suspicion and you did an angio, well managed. Okay.
Yes. Thank you.
Dr. Neenawat, are you ready with your PPT?
Yes, ma'am.
Can you present it?
Yes, ma'am. Oh, good morning, ma'am. This is Dr. Neenawat Pravalika Rathod, the second year PG resident, ma'am. My case is a rare case of rudimentary horn pregnancy in which we did left horn dissection with left salpingo, laparoscopic left horn dissection with left salpingo oophorectomy. And so introduction, a unicornuate uterus with rudimentary horn is uterine anomaly resulting from the incomplete development of one Mullerian duct or incomplete fusion with the contralateral side. Pregnancy in a rudimentary horn of the uterus is a rare clinical condition with incidence of 1 in 1 lakh pregnancies. Majority of the cases are diagnosed late when they present in the emergency after rupture with hemoperitoneum. The use of ultrasonography helps in diagnosis of uterine malformations and ectopic pregnancies earlier. So the case report is in a 19-year-old female patient, primigravida with 3 months amenorrhea, presented in our ANC clinic with complaints of abdominal pain since 5 days with spotting PV since 1 day. She was hospitalized for observation and further evaluation. Her vitals were stable. On examination, patient was conscious and well oriented. Her general condition was fair. Per abdomen examination, abdomen was soft. Per vaginally, uterus was enlarged, deviated to right side. Exact size was not able to be made out. A freely firm mobile, a mobile mass of around 5 to 5 centimeters was palpable in left fornix. Right fornix was free. Non-tender cervical motion tenderness was present. On investigations, on USG findings, there was suggestive of single live pregnancy with 11.3 weeks gestational age in left tube and ruptured with possibility of corneal pregnancy. Rest all routine ANC investigations were done and came to be normal, and beta HCG was also within normal limits. Management, intraoperative findings were evident of round ligament fallopian tube arising from corneal end of enlarged structure suggestive of left horn of uterus. Right horn, fallopian tube and ovary was normal. Left horn was congested, tense and bulging and was connected to right horn with a fibrous band suggestive of unicornuate uterus with rudimentary horn with pregnancy in that horn. She underwent laparoscopic left horn dissection with left salpingo oophorectomy. The specimen was delivered by side port. Postoperative course was uneventful. Discussion. Patient with advanced extrauterine pregnancy should raise suspicion of Mullerian duct anomalies. Incidence is estimated to be 0.5% to 4.2% of general population. Unicornuate uterus with or without rudimentary horn has an incidence of 5 to 10% of all women with Mullerian anomaly.
It's time for question.
Dr. Rathod, can you hear me?
Yes, ma'am.
Why was oophorectomy done for her?
Ma'am, because of the when the enlarged when the enlarged uterus was it was unable to save. We were unable to save the ovary, ma'am.
It doesn't look like that by the picture. Whatever picture is showing, it looks pretty savable, man. Removing ovaries is it advisable in a girl who's not yet had any pregnancy? This is the first pregnancy, right?
Yes, ma'am. Primigravida, ma'am.
I don't understand.
It's only 19 years.
Yes,
that's what. See, by chance she develops some benign mass on the other side, and that ovary also goes up. What will you do? You should really think twice before removing the normal ovary in young girls like this.
Yes, ma'am.
I don't have anything else to say.
So was MRI was done for this lady? No.
No, ma'am. MRI wasn't done.
Diagnosed in ultrasound only.
Yes, ma'am.
Okay.
Yes.
Dr. Sushma, can you share your Dr. Sushma Shri? Sushma Shri?
Is she logged in?
She has started sharing. What happened, man?
Dr. Sushma Shri?
Unmute yourself, Rishma.
Dr. Sushma Shri. You are not audible. Ma'am, shall we move with the other person, ma'am?
Yeah. Nandini has joined back.
Dr. Nandini, can you share your slide?
Yes, ma'am. Yes, ma'am.
Share your slide and start presenting, please.
Ma'am, somebody else is sharing, ma'am.
Dr. Sushma Shri, can you?
Sushma Shri, can you?
Dr. Sushma Shri.
Dr. Sushma Shri.
Dr. Nandini, can you share it now? Dr. Nandini? Dr. Nandini, can you share it now?
Dr. Lavanya.
Ma'am?
You could have asked them to send it to you beforehand and you could have done it yourself. This is causing so much of delay and unnecessary waste of time, right? Anyway, it is just one slide. They could have submitted to you, the organizers beforehand, right?
Ma'am, we
Dr. Sushma Shri, can you stop sharing? Dr. Sushma Shri, can you stop sharing your slides? Dr. Nandini, can you try to share it? Dr. Sushma Shri has shared. Dr. Nandini,
Yes, ma'am.
can you share it?
Yes, ma'am. Can you hear me, ma'am?
Slide is not visible.
We can hear you, but we are not able to see your presentation.
Seeing it.
I'm not able to share, ma'am.
Dr. Lavanya, please ask rest of the participants to send the presentation to you. We still have 10 plus to 12 to go.
Okay, we will coordinate it.
Sushma, see if you can share. Who's this now? Sandra.
Dr. Lavanya, these two kids are not ready. Can we move on to the next session? We can
Yeah.
come.
Do that. Don't. Somebody is shared. Who's this?
Dr. Sushma Shri, did you share your slides?
Yeah, share. You can see her slide. Let her start presenting.
Can you start presenting? Dr. Sushma Shri. Dr. Sushma Shri, you are not audible. Dr. Sushma Shri.
let's move on to the next part, man. Anybody else can?
Dr. Sushma Shri, at least can you stop sharing your slide? So others can proceed with it. Dr. Nandini, can you start sharing now? Try to share it. Dr. Nandini?
Hello.
Can you start sharing now?
Ma'am, I'm not able to share, ma'am. I put in the chat box.
Okay, okay.
Dr. Lavanya?
Dr. Sushma Shri, can you stop sharing it? Until you stop it, we can't share any other slides. Dr. Sushma Shri? Fatima, can you share your slide? Dr. Fatima? Fatimas? Dr. Fatimas? Can you stop sharing otherwise?
Good stuff, sir. Woman can share this.
Fatima, did you got the instructions that you have to present through a laptop and all?
Fatima, can you stop sharing it?
Yes, ma'am. Yes, ma'am. Okay, ma'am.
Dr. Nandini, Dr. Nandini, Dr. Nandini, share yours and start presenting.
Ma'am, I'm not able to share, ma'am.
Nandini, please mail your presentation to the organizers and don't try to share again. Same thing for the other doctor, who's that? Dr. Sushma Shri. Don't try to share. Please mail your presentation to organizers.
Dr. Lavanya, make these two kids to present in the end. Tell them to not to interrupt now.
Yeah, it's been almost
to the second session.
This now.
Ma'am, I'm able to share, ma'am. Can you see?
No problem.
Who is this? Nandini, start presenting.
Yes, ma'am. Myself, Dr. Nandini, second year postgraduate, Saptagiri Medical College. I'm here to present a rare case, central dural venous thrombosis, presenting with lateral rectus palsy. Introduction, the cerebral dural venous sinus thrombosis, it is a rare condition. Headache, of vision, macular edema, confusion are the common symptoms.
Make it full screen, ma'am.
It's visible. Let her present it.
It is relatively life-threatening condition. Risk factors will include severe dehydration in third trimester of pregnancy, malignancy, sinusitis, hyperkalemia,
Kanya, can you mute yourself?
Palsy can occur for a variety of reasons. The case report, she was an 27 years female, married since 12 years, G2P1L1 with 32 plus 3 weeks of gestation with history of obesity and prior pregnancy 4 years earlier. She presented to us with complaints of headache, blurring of vision, inability to close left eye since past 24 hours. The patient was evaluated 2 weeks prior to the admission, and she was diagnosed to have gestational hypertension, hypothyroidism, and gestational diabetes mellitus. But she was not started on any treatment, and she was referred from outside to our hospital. She had no history of fever, head injury, or any other trauma. At admission, the patient had BP of 160 by 100 mm Hg with proteinuria. So we started around labetalol 200 mg BD, and when on fundoscopic examination, she showed grade 3 hypertensive retinopathy, and extraocular muscle examination showed right eye lateral rectus palsy and right eye esotropia and left eye nystagmus and mild ptosis. And our blood pressure was under control on tab labetalol 200 mg BD, and MRI was done, brain and orbits with venogram, and it was reported, she was reported to have central dural venous thrombosis involving anterior half of the sagittal, superior sagittal sinus. Then neurology team started her on injection Clexane 60 mg BD, and along with that they started her also on tab Citram 3 mg OD. And they had asked us to monitor our INR daily and maintain it above 2.5. And the patient on that treatment, she has maintained well, and neurological symptoms improved by other 10 days. And she was discharged on 11th day on tab acitram. We started tapering the dose 2 mg. Later, patient was followed up with us, and she was planned for elective cesarean section at 38 weeks. And we stopped acitram 5 days before the surgery, and she delivered a healthy male baby, and she was put her on anticoagulants post-operatively for 5 days, injection Clexane, and she was discharged from us, and all her symptoms improved gradually, and when discharged she had normal.
Time up. It's time for discussion, ma'am.
Why elective section?
She was previous LSCS also, ma'am.
Okay. Post-op management?
Post-operatively for 5 days, we gave her an injection Clexane 60 mg BD, ma'am. Like on the day of discharge, we stopped completely and we sent. After 1 month, she had come for follow-up. She has recovered fully.
Only for 5 days you gave and then you stopped it?
5 days we gave, ma'am. Then we stopped it, ma'am.
Why? At least 6 is supposed to give. No, she had a thrombotic event during the pregnancy, right?
Yes, ma'am. And we had given her before pregnancy from 32 weeks till 38 weeks, she was on Clexane and acitram, ma'am.
I know that, but following delivery, first 6 weeks are still high risk for thrombosis, right? She's come to you with an unprovoked thrombotic event.
Yes, ma'am.
Why only 5 days was given, ma'am? Okay.
Okay. Next.
Dr. Ramya. Dr. Ramya. Dr. Ramya. Dr. Ramya Shravani. Can you start presenting?
This is the second session, Lavanya.
Hello, madam.
Dr. Ramya Shravani, can you start presenting? Can you share your slide?
Dr. Lavanya, what about Prabha and Kavita Mani?
Ma'am, both are not answering the calls, ma'am. They are not in, and also they are not answering calls.
This is Dr. Ramya, right? Ramya Shravani. The
Shravani.
14th. Okay.
First, ma'am.
Okay.
Start presenting Ramya Shravani.
Start.
College Tirupati. Good morning, ma'am. I'm second.
Your voice is echoing, ma'am.
Hello, madam.
Ramya, can you off your another device?
Yes, ma'am. Hello, ma'am. I'm Ramya Shravani, second year postgraduate. SV Medical College, Tirupati. I'm going to present my case report of Mullerian agenesis. A case of a 17 years old woman who presented with no onset of menstrual cycle. Her height was 148 centimeters, weight 42 kg, and blood pressure 120/70. No other affected members in the family were detected. At clinical examination, the patient demonstrated development of secondary sexual characteristics compatible with her chronological age. Hormonal studies were in normal limits. On examination, secondary sexual characters were developed. TANU stage 5 will be noted. Blind vagina of 1 into 1 centimeter small size noted anteriorly. On parectoral examination, 1 into 1 centimeter small size noted anteriorly. Transabdominal ultrasound demonstrated the presence of the uterus. There was a difficulty in visualizing the ovaries. In MRI, we find that the uterus was not distinctly visualized. A very thin streak-like structure noted of size 1.8 into 0.3 centimeters without proper endometrial delineation noted. Ovaries were visualized with good volume. No cervix or vagina delineated. Coming to discussion, Mayer-Rokitansky-Kuster-Hauser syndrome is a form of Mullerian agenesis and is a cause of primary amenorrhea in females. It is characterized by the absence or hypoplasia of structures derived from Mullerian ducts, namely the uterus, cervix, and the upper vaginal canal. 25% patients has short vaginal pouch. Rudimentary tubes are often present. Secondary sexual characters are normal. Karyotype is 46XX. It occurs in 1:5,000 to 1:20,000 women at birth and is diagnosed approximately in 1:1500 gynecological admissions. For a long time, the syndrome is considered as a sporadic anomaly, but increasing number of familial cases now supports the hypothesis of genetic cause. Familial tendency present in 7 to 8% of the cases. However, etiology remains still unclear. Mayer-Rokitansky-Hauser syndrome may be isolated type 1, but more frequently associated with renal, vertebral, and to lesser extent auditory and cardiac defects. MRKH type 2 syndrome. In MRKH type 2, treatment of vaginal aplasia, which consists of creation of a neovagina, can be offered to allow sexual intercourse. As psychological distress is very important in young women with MRKH, it is essential for the patients and their families to attend counseling throughout and before treatment. There is a possibility of conception by donor oocyte and surrogacy. Coming to the conclusion, MRKH syndrome is one of the most common cause of primary amenorrhea, and ultrasonography is useful for diagnosing any associated renal anomalies. MRI is more precise than ultrasound and less invasive and expensive than laparoscopy, contributing significantly to treatment planning and patient management. Although this condition has psychologically devastating
It's time for discussion, ma'am.
anatomical defects can be surgically treated, allowing a normal sexual function and
interrupt.
reproduction. Thanks to
Ravani,
this. So,
Ravani, what is the other condition which will have well-developed? Ravani?
Shravani, can you hear us? Dr. Ramesh Ravani, can you hear us?
Yes, ma'am.
Yeah, what is the other condition which will have well-developed secondary sexual characters and absent uterus?
Madam, by doing karyotype examination 46X.
No, what is that condition?
Can be the condition, ma'am. Androgen insensitivity syndrome can be the one more DD, ma'am. And the karyotyping will be 46XY, ma'am.
No. How do you distinguish clinically between these two conditions? MRKH and androgen insensitivity syndrome.
Ma'am, in androgen insensitivity syndrome, it is also known as testicular feminizing syndrome, ma'am. In that, external genitalia resembles female, ma'am.
No, I'm asking how do you distinguish between these two? Don't beat around the bush, please.
Breast. Secondary sexual characteristics of male will not develop, and breast development occurs, madam, in that also.
You're not getting my question, ma. How do you distinguish clinically?
Pubic hair and axillary hair does not develop properly in that, ma'am. Tanner stage 1 or 2 will be there, ma'am.
Okay, that's what is the answer, not all the things what you told me. Okay, thank you.
Okay.
Thank you, ma'am.
Dr. Ramya A. Dr. Ramya A, can you start presenting?
Yes, ma'am.
Shravani, can you stop sharing?
Yes, ma'am.
Ramya A, share your slide, please.
Ma'am, shall I start the presentation, ma'am?
Yeah, start presenting.
Good afternoon, ma'am. I'm Dr. Ramya from Dharmaburi Medical College, ma'am. I would like to present giant glioma mimicking an ovarian tumor, presenting with an unusual obstructing symptom, ma'am. Introduction: glioma of the uterus is the most common type of tumor affecting reproducing age group of women, arising from the uterine smooth muscles. Incidence increases during the reproductive age and decreases after menopause. Its pathogenesis is related to estrogen and genetic predisposition. The maximum incidence of 40% is observed in the woman of age group between 30 to 50 years. Its size varies from few millimeter to centimeter. Diagnosis of fibroid is usually made with USG and MRI. However, in the case of large pedunculated fibroid with cystic degeneration, the diagnosis is difficult and can be misdiagnosed as ovarian tumor. We present an unusual case of large glioma mimicking an ovarian tumor. And the aim and objective of my presentation is to describe a rare case of glioma which present with diagnostic difficulty and an obstructing feature in our college. And our case report is a 25-year-old nulliparous woman presented with complaints of abdominal distension for 6 months, abdominal pain and breathlessness for 1 month. In the menstrual history, she attained menarche at 13 years with regular cycles. On general examination, the general condition was fair, affable, pallor with a unilateral pedal edema present on the left lower limb. CVS and RS is normal. On per abdomen, a large mass occupying all quadrants of abdomen with 34 weeks of gravid uterus size. Its surface was smooth, variable in consistency and non-tender, and lower margin was non-palpable. On per speculum examination, cervix was normal. On PV examination, fornices full, uterus was not separately palpable. USG examination, a large complex mass of abdominal pelvic origin. Both ovaries could not be separately seen, and diagnosis when ovarian cyst was made, and further we are evaluated with CECT. And the CECT report revealed heterogeneous mass of pelvic origin with areas of necrosis. Uterus is normal, ovaries could not be separately visualized, no free fluid in the peritoneal cavity, and no significant lymphadenopathy was seen. And the tumor markers were normal. We did Doppler USG for left lower limb, and we diagnosed DVT, and patient started an anticoagulant, and echo was done to rule out pulmonary embolism. We planned for a laparotomy with a consent to get hysterectomy with the bilateral salpingo-oophorectomy. But during laparotomy, it was surprised to see a large mass of size 25 cross 20 cross 16 centimeter rise from fundus of the region. It's probably of leiomyomum. Myomectomy was done and specimen was sent for histopathology. Post-operatively, anticoagulants were started after 12 hours of surgery, and post-operatively, patient was uneventful and patient was discharged on the 12th POD. And our microscopic finding was benign leiomyoma with hyaline cystic and myxoid degeneration. And my discussion part is uterine fibroids are non-cancerous growth in the uterus. Based on the location, they are classified as submucosal, intramural, or subserosal. Subserosal may be pedunculated and simulate ovarian tumors. Large uterine fibroids can cause abdominal pain, constipation, increased frequency of menstruation, and excessive bleeding.
It's time for discussion, ma'am.
Why you have taken consent for THPSO as a primary surgery? She's a young lady, nulliparous. There is no suspicion for any malignancy because no tumor marker elevation, no ascites.
But with the CECT finding, we thought it as ovarian cyst, ma'am.
Tumor markers are normal.
Tumor markers are normal, ma'am, but we thought
no ascites.
No ascites, ma'am.
So the benign condition, they'll have a solid.
Yes, ma'am.
So the benign condition of the ovary, they'll have solid components.
Uterine mass may contain like
ovarian mass mimic like a fibroid.
Yes. So for degeneration may look like that, ma'am.
No, Dr. Ramya, if it was a huge fibroid with areas of necrosis, what else you should think of? Even when you opened the abdomen, you found it was arising from the uterus.
Adenomyosis.
Adenomyosis. Why would you think of adenomyosis?
What is the histopathology you said?
Yeah, benign leiomyoma with hyaline cystic and myxoid degenerations.
Was it stuck in the pelvis? What led to the DVT?
Large mass obstructing the venous outflow. So
no, where was the obstruction? Could you make out surgically? Because fundal fibroid is not expected to go and sit in the pelvis and compress lateral pelvic wall. No? How was it?
It was very large mass, ma'am. Fast, large vein obstruction.
The way we done, surprisingly, we found one fundal fibroid. We just did a myomectomy and came out. Looks like a relatively simple surgery. Was it like that?
Yes, ma'am. During surgery, it was like that.
Okay, fine. Thank you.
Okay. Next student.
Thank you.
Ranjita. Dr. Ranjita.
Yes, ma'am. Yes, ma'am.
Can you share your slide?
Yes, ma'am.
Dr. Ramya, can you stop sharing it? Dr. Ranjita, can you share your slide?
Yes, ma'am. Should I start, ma'am? Hello?
Yeah, present. Start present.
Good morning, ma'am. I'm Dr. Ranjita, final year PG from WIMS and RC, Vaidya Institute of Medical Sciences, Bangalore. I'm presenting a case report on spontaneous ovarian hyperstimulation syndrome with primary hypothyroidism, a rare case report. Introduction: ovarian hyperstimulation syndrome is an iatrogenic condition associated with ovulation induction therapy. Spontaneous ovarian hyperstimulation is ovarian stimulation in patients without ovulation induction, of which very few cases have been reported. Case details: a 23-year-old unmarried female presented with complaints of lower abdominal pain and vomiting for 4 days, loose stools for 1 day with 6 to 7 episodes per day. She had been evaluated elsewhere and advised emergency exploratory laparotomy for large ovarian cysts, and she was referred to WIMS and RC. She had an irregular cycle since age of menarche. It was a 35 to 45 day cycle with a normal flow. She's also a known case of hypothyroidism since 11 years. She had been on levothyroxine 100 microgram once daily, which she had discontinued prior to 2 months. On examination, patient was hemodynamically stable. She had showed features of hypothyroidism like cold extremities, dry skin, facial puffiness. There was no organomegaly or abdominal tenderness. Investigations was sent, which showed hemoglobin of 7.3 on day 1 of admission, and TSH was 126, FT3 was 1.56, FT4 was 0.06, FSH was 8.74, TPO antibodies were 5.5, creatinine was 1.01. Electrolytes were normal. PT-INR also was on the in the normal range on the day 1 of admission. USG done showed bilateral bulky ovaries with right ovary measuring 7 into 7 into 5 centimeter with a volume of 160 cc, and left ovary measuring 3 into 5 into 4 centimeter of volume 50 cc with minimal ascites. CECT, which was done outside, showed bilaterally enlarged ovaries, and chest X-ray was normal. These are the images which are showing multiple follicles. Management, diagnosis of spontaneous OHSS grade 3 was made since she has vomiting, diarrhea, and minimal ascites on ultrasonography. She was started on IV fluids and tablet levothyroxine 100 microgram, tablet terbinafine 0.25 mg OD, and IV antibiotics in vivo flu stools. Scan, which was done after 3 days, showed reduction in ovarian volume of both the ovaries, of which right ovary was 151 cc and left ovary was 46 cc. Abdominal pain, vomiting, and diarrhea resolved after 4 months, 4 days of admission. She is being followed up. Discussion: all women who are undergoing ovarian stimulation are at risk of developing OHSS. In this case, spontaneous OHSS was associated with primary hypothyroidism. Main pathology being HCG causes release of vasoactive peptides, that is vascular endothelial growth factor from the granulosa cells, which causes increased vascular permeability with loss of fluid into extravascular space, and also causes hyperviscosity, hemoconcentration, and hypocoagulability. Here, since TSH resembles alpha unit of HCG, this causes increase in follicle FSH and stimulates the follicles and causes OHSS.
Sorry
Conclusion.
to for discussion, ma'am. It's time for
Yes,
discussion.
Okay.
No, did you check any serum estradiol levels?
Estradiol was not sent, ma'am. Estradiol and HCG both was not.
Normal or?
It was not done, ma'am.
It was not done. Okay.
Yes.
Okay. I think we can move ahead.
Okay.
Dr. Srimati, can you start presenting? Dr. Srimati. Dr. Srimati, can you start presenting?
Hello.
I'm Dr. Ray.
Hello,
Ma'am.
Hello.
Start presenting.
Hello, ma'am. Can I present?
Yeah. Start present.
Start.
I'm Dr. Srimati, pioneer postgraduate from Tanjore Medical College, Tanjore. Here is the case report of hypermesis gravidarum. It is vernicus encephalopathy. Introduction. It's hypermesis gravidarum is excessive and protracted vomiting in pregnancy, incapacitating and daily day-to-day activities or deteriorating the health of the mother. The aims and objectives is to describe the rare clinical presentation of vernicus encephalopathy in pregnancy. The main purpose of the study is to improve its awareness and early diagnosis, to know about the maternal morbidity and fetal outcome of the disease. Here I am presenting the case report on vernicus encephalopathy secondary to hypermesis gravidarum caused by thiamine deficiency. Here is the biological active form of vitamin B1 is thiamine pyrophosphate. It is an active coenzyme in many pathways of the brain, including transketolase, alpha ketoglutarate, and dehydrogenase and pyruvate dehydrogenase. A 23-year-old female is a gravid 3 para 2 live 2 with a previous 2 normal vaginal delivery. Her ED is 6/4/2022. Admitted at 16 weeks of gestation with the complaints of excessive vomiting for the past 2 months, with the complaints of blurring of vision, difficulty in walking for the past 10 days. Previous pregnancies were uneventful. On examination, patient is conscious oriented with nystagmus, and CNS examination revealed no bilateral pupils equal reacting to light, extraocular movements, full carbohydrate spasm plus with no weakness of upper limb. Gait could not be assessed. Sensory is normal. No neck stiffness. Finger nose test patient is able to do. We further initial evaluation was done, and power was noted to be decreased in the upper limb than the lower limbs, and the dependent reflexes are progressively reduced, and plantar reflexes are flexor. Tone is also normal. The MRI brain is revealed as a possibility of Wernicke's encephalopathy, subtle T2 and flare hyperintensity with a mild diffusion restriction over the medial thalamus. It was impression was given as a possibility of Wernicke's encephalopathy. Cardiac evaluation echo shows normal steady. And after the evaluation, it was revealed that horizontal engaged nystagmus with blood discharging with flame-shaped and blood hemorrhages seen around the disc. It is probably Wernicke's encephalopathy. Nerve conduction study was done. It was mentioned as a bilateral peroneal axonopathy along with sural sensory axonopathy, acute onset paraparesis. And laboratory investigations shows a normal electrolyte levels with SGOT, SGPT, SGOT is 28 and SGPT is 16. And serum thymic level is 37 nanomoles per ml, and hemoglobin was 6.1, and his anemia was treated. So the patient was started on injection timing. Patient was started injection timing 200 mg IV bleeding, normal saline, and syrup cases was started after improvement in general condition of the patient. Patient was shifted to oral tablets. Physiotherapy was continued with active passive limb movements. There is improvement in vision. On 25th day of admission, patient able to walk with support with resolving eye lesions, and the patient got discharged in 1 month. Conclusion: although Wernicke's encephalopathy is reversible, it can lead to permanent neurological lesions and Wernicke-Korsakoff syndrome, which is fatal in 10 to 20% of cases. In a review of 49 reported cases, conclude the symptoms resolution required often months, and complete remission is obtained only in 14 cases. Spontaneous fetal loss rate was 37%, and elective abortion rate was 10%. In conclusion, any pregnant woman with thiamine supplements and if she develops some neurological manifestations, Wernicke's encephalopathy should be considered. MRI is the most useful investigation diagnosis. Serious management of vomiting women in women during pregnancy and thiamine supplementation patients who are neurological symptoms can recruit.
It's time for discussion, ma'am.
Yeah.
Okay.
What was the follow-up after that?
Ma'am, patient is now delivered by normal vaginal delivery, ma'am.
Okay.
Institution.
Post-delivery?
We have started on thromboprophylaxis, ma'am. Low molecular weight heparin was started, ma'am, and electrolytes and all were normal. Patient is walking without support and is clinically improved, ma'am.
No, low molecular weight heparin, why?
Because of high risk of thromboprophylaxis, we started on low molecular heparin.
What do you mean high risk of thromboprophylaxis?
High risk of hemo concentration.
Why, man? You mean you start for all postnatal ladies?
No, ma'am, because she is affected by Wernicke's encephalopathy, there is risk of thromboprophylaxis is kind. Thromboembolism is kind, ma'am.
Knew this.
So we prophylactically start.
Okay.
Next.
Dr. Fatima Zoe.
Yes, ma'am.
Can you share your slide? Srimati, can you stop sharing your slide?
Yes, ma'am.
Fatima Zohar, can you share it?
Yes, ma'am.
Fatima Zohar, share your slide and start presenting.
Sharing, ma'am.
Stop sharing.
Good afternoon, ma'am. This is Fatima, second year postgraduate from Government Medical College, Tirupati, ma'am. This is a case of mass per abdomen, a case report of a rare syndrome called von Wag-Rumbach syndrome. The clinical presentation of the patient is a 13-year-old female came to OPD with a complaint of mass per abdomen, intermittent abdominal pain with vaginal bleeding since 5 days. There was no history of urinary symptoms and bleeding per rectum or visual disturbances or gait disturbances. There was no developmental delay, headache or vomiting. On examination, she was 84 centimeters, short statured, and weight was only 15 kilos. She was Tanner stage 2 breast development. There was no axillary or pubic hair. A solid mass of 7 into 6 centimeters was noted, extending from right iliac to left iliac fossa. There was no tenderness, no free fluid. On examination of her perineum, the perineum and genitalia was normal. The clinical course of the patient is when she was investigated, it revealed that hemoglobin is only 8 gram per deciliter, suggesting anemia, and the serum TSH was 100 micro units per ml with hypothyroidism, and basal FSH was 2.3 milli international units per ml, and LH was 0.02 milli international units per ml, and prolactin was 20 picogram per milliliter. The bone age was delayed by 3 years. This was done with the help of X-rays of the patient of hands and legs, ma'am. On ultrasound of the pelvis, it showed multiple cysts in both ovaries. The largest cyst measuring 10 into 5 centimeters on right side with few hemorrhagic cysts. And MRI brain was done for her, and it showed enlarged pituitary gland, ma'am. Then patient was started with levothyroxine 50 micrograms per day, and patient was the cysts and the symptoms of the patient improved slowly. With 6 months of treatment, the patient recovered almost to 50%, ma'am. And coming to discussion on the untreated hypothyroidism is usually associated with delayed puberty, but occasionally it is associated with isosexual precocious puberty. As in this case, it is known as von Bragg-Gumbach syndrome, ma'am. This syndrome is associated with hypothyroidism, precocious puberty, and delayed bone age. This entity is characterized by untreated hypothyroidism, precocious puberty, and ovarian hyperstimulation, leading to ovarian cysts, ma'am. The treatment with levothyroxine will completely reverse the pubertal signs and the cysts in the ovaries, and the patient will be absolutely normal if treated in a correct time and correct way with levothyroxine. And coming to conclusion, the chronic hypothyroidism with high levels of TSH, isoprecocity, and delayed bone age of von Bragg-Gumbach syndrome is the only form of precocious puberty in which bone age is delayed, ma'am. Early identification and initiation of thyroid hormone replacement will suffice the treatment, and patient will be absolutely normal, ma'am, without having any surgical interventions.
When did she attain menarche?
Patient did not attain menarche, ma'am. That was the first day she came with vaginal bleeding.
So
Those 5 days were only.
precocious puberty?
You're saying
She
Why
was
are you
only
labeling
13.
precocious puberty?
She was only 13 years, ma'am.
13 years is the normal age.
What's wrong with you? Dr. Fatima, please be clear what exactly you want to convey the message.
Madam?
Do you think this is precocious puberty because she was 13 years and she had menarche?
Madam, the 13 years which she is stating is doubtful for her, ma'am. According to the bone age which we have calculated, it is delayed by 3 years. Her weight was only 15 kilos only, ma'am. She was by Tanner staging and by physical examination, she was only 9 to 10 years old, ma'am.
9 to 10 years.
Yes, ma'am.
Okay, ma'am. Next candidate, please.
Okay, thank you, ma'am.
Dr. Silitra,
Yes, ma'am.
can you share your PPT?
Yes, ma'am. Shall I start, ma'am?
Please start.
Good afternoon, everyone. I'm Dr. S. Sinitra, second year MS OG from Kanyakumari Medical College. This is a rare case report on autoimmune encephalitis in pregnancy. Introduction: anti-NMDA receptor encephalitis was first reported in 2005 in 4 patients with ovarian teratoma. It's a type of autoimmune synaptic encephalitis more common in young women with associated with ovarian teratoma, has a female predominance targeting women of childbearing age. It is sometimes misdiagnosed as a psychiatric disorder or viral encephalitis, principally associated with the antibody against NR1 subunit of NMDA receptors. Aims and objectives. The aims is to describe a rare case on autoimmune encephalitis in a pregnant woman at Kanyakumari Government Medical College who had a successful outcome. Materials and methods. This is a 23 years old G2P1L1 previous LSCS, 21 weeks of gestational age, presented with complaints of multiple episodes of seizures, history of involuntary movements, and decreased interaction. On admission, patient was conscious, not oriented, and not responding to oral commands. Her blood pressure was normal. Routine blood investigations done, no specific abnormalities detected, and MRI shows cortical thickening and increased intensity in the mesial temporal lobes. EEG shows borderline epileptiform activity, and CSF analysis done, which showed lymphocytic pleocytosis. We initially considered her symptoms were indicating a viral encephalitis, and empirical therapy with acyclovir was started. After admission, patient again developed 2 episodes of seizures and was maintained on anti-epileptic drug. And during her stay in the intensive care unit, the fetus miscarried. After 2 weeks of admission, serum and CSF was positive for NMDA receptor antibodies. Results: the patient been treated with IV methylprednisolone and IV immunoglobulin for 5 days. And after this treatment, we maintained her on oral corticosteroids and antiepileptics. We performed a transabdominal ultrasonography to detect the ovarian teratoma, but there was no teratoma. After a treatment course of about 2 weeks, the patient was able to obey one-step command, and after 3 weeks, she was able to ambulate with a walker. Her speech was fluent. 1 month after discharge, she was functioning independently at home. Discussion: anti-NMDA receptor encephalitis is an immune-mediated disease. The clinical course begins with viral prodromes, followed by a seizure and also behavioral disturbances. Sometimes coriform movements was also there. Half of these patients show MRI irregularities, and in most cases, EEG is abnormal. CSF findings include lymphocytic pleocytosis. The final diagnosis is based on the presence of IgG antibodies against NMDA receptors in the serum or CSF. Conclusion: the use of early and aggressive immunosuppressive treatment, that is corticosteroids, IV immunoglobulin, and plasma exchange, along with the removal of the ovarian teratoma if present, can lead to positive outcome in 80% of the patients, and the mortality is estimated to be 4%.
Okay. Dr. Sinitra.
Yes, ma'am.
But who thought of sending serum and CSF for NMDA receptor studies? Neurologist or?
Yes, ma'am. We got for neurophysician opinion. Initially, we didn't send for NMDA receptor antibodies, but even the CSF analysis, everything was negative for other organisms like tuberculosis. That all, AFB stain. That all we sent, but everything was
okay. That's fine. Good case.
Only one correction. It's a case report. You should not include all this material, methods, and results. So the main drawback is that. Okay.
We are presenting, even in your aims and objective, we have written women at Kanyakumari. I thought you're going to have multiple cases of this rare disorder, the way we are presenting. Understood?
No.
So
have you attended this biomedical course?
Original study. This is not original study, no?
It's a single case report.
Single case report, ma'am.
Have you attended your biomedical course?
Yes, ma'am.
So there's a differentiation how to write an article, how to put a presentation and all. Next.
Next candidate.
Thank you, ma'am.
Dr. Aishwarya. Dr. Aishwarya. Please share your PPT.
Yes, ma'am. Ma'am, I'm not able to share my screen, ma'am.
Aishwarya.
Ma'am, I'm there. I'm not able to share my screen, ma'am.
Share it in the chat box. Share it in the chat box.
Ma'am, no, I'm not able to open it, ma'am.
Can you share it in chat box?
Ma'am, I'm not able to do that. I'm trying to open it on the chat box, but I'm not able to do that.
Can you share it in the group?
Yes, ma'am, it's already been shared in the group.
It's not there in the group.
Ma'am, I've shared it in the group, ma'am.
I'm not able to find it. Can you share it?
Yes, I'll resend it, ma'am. Just a minute. Yes, ma'am, I've sent it. Is it seen, ma'am?
Okay, wait, we'll try to share it.
Yes, ma'am.
Dr. Shushma Sri.
Yes, ma'am.
Kindly share your PPT now.
Can you hear, ma'am?
Yeah, can you share it?
Yeah, sure. Can I present, ma'am?
Yeah, can you start presenting?
Okay, ma'am. Good afternoon, ma'am. I'm Dr. P. Sushma Sri, OBG resident from MBJ Medical College. My poster is on a rare case report of huge mucinous cystadenoma of the ovary. Coming to introduction, epithelial neoplasms of the ovary account for 60% of all ovarian tumors and 40% of benign tumors. They classify as benign, borderline, and malignant. Ovarian cystadenomas are common benign epithelial neoplasms which carry an excellent prognosis. The two most frequent types of cystadenomas are serous and the mucinous cystadenomas, whereas endometrioid and the clear cell cystadenomas are rare. Despite advances in imaging studies, the establishment of a definitive diagnosis of the cystadenomas is primarily by histopathological examination of the surgical specimen. This review will focus on the ovarian cystadenomas and their histopathological features. Coming to case report, a patient, 45-year-old, came para to live to, came from low socioeconomic status, presented with complaints of abdominal distension since 1 month. On examination, abdomen was distended up to 36 weeks, and the mass is soft in consistency, and it is a non-mobile mass. On perspiculum examination, cervix and vagina found to be healthy. On PV, cervix is pulled up and a mass of 36 weeks was felt. Coming to investigations, USG abdomen and pelvis showed a large cystic lesion from the left egg nexa, measuring 20 cross 20 cross 18 centimeters. CACT of abdomen and pelvis was done, showed a large cystic lesion with internal septations from the left egg nexa, measuring 21 cross 27 centimeters. We did a tumor marker CA125, 7 nanograms per ml. It was normal. And coming to treatment, exploratory laparotomy was done. A huge cystic lesion of size 20 cross 25 centimeters from the left ovary was occupying the abdomen from pelvis to diaphragm. The cyst was fluid, multiloculated. The extent of tumor was identified, and the total abdominal cystectomy with bilateral salpingo-oophorectomy was done. Lymph nodes are not involved. Right ovarian cyst was cystic and it was removed. Appendicectomy is done, and the post of patient is uneventful. Histopathological report came to be left ovary mucinous cystadenoma. Coming to discussion, mucinous cystadenoma is a benign ovarian tumor. It is reported to occur in the middle-aged woman. It is a rare among adolescents or in association with pregnancy. On gross appearance, mucinous tumors are characterized by cysts of variable sizes without surface invasion. Only 10% of primary mucinous cystadenomas are bilateral. Section shows multilocular, sometimes capillary growth arising from the septum may be seen. The cyst was filled with sticky gelatinous fluid rich in glycoprotein. Histologically, mucinous adenoma, cystadenoma
for discussion. It's time for discussion, ma'am. Sorry to disturb, ma'am.
Yeah, what other surgery done for this lady?
Ma'am, total abdominal cystectomy with bilateral salpingo-oophorectomy was done, ma'am. And previously, there is no history of any surgeries for her. And appendicectomy we did as it was, we suspected it was mucinous, and pseudomyxoma peritoneae to rule out, we did appendicectomy also.
What is rare in this case?
Yeah, what is rare in this case?
Ma'am, what did I hear you?
What is rare in this case?
Rare, ma'am?
You said it's a rare use mucinous cyst, your presentation. It's a 25 centimeters. It's mucinous.
Ma'am, usually in epithelial cell tumors, serous cystadenoma is 75%, ma'am, and mucinous will come to be like 10%, only 10% in all ovarian tumors, benign ovarian tumors.
You know, these mucinous cystadenomas are generally called as giant mucinous cystadenomas. They can grow to huge sizes. It can go up to xiphisternum.
Yes, ma'am.
Okay.
Yes,
you're a postgraduate, you wanted to present something. I'm happy that you have that attitude, but there is actually nothing rare in this case, ma'am. Please remember that, okay?
Okay.
Manage in some other way or something, I can understand, but 45-year-old, no dilemma in the management, nothing. So nothing much to discuss in this particular case. Thank you.
It's a clear-cut case for surgery.
Yes.
Thank you, ma'am.
Yeah.
Are we done or anybody else is presenting?
Only one is left, ma'am. Dr. Aishwarya.
Yes, ma'am.
Yes, that's carrying the PPT.
Yes, ma'am. Ma'am, it's coming as you cannot share when another participant is sharing.
It's already shared. You can start presenting.
Okay, ma'am. Good afternoon, ma'am. I'm here to present a case on bilateral dermoid cyst, that is mature cystic teratoma, in a 50-year-old lady, a 56-year-old lady. To start with my case, the 56-year-old female patient came to the gynecological OPD, ma'am, with complaints of pain abdomen since 1 week. The patient was examined thoroughly and a provisional diagnosis of ovarian cyst was made. Then an ultrasonography was done and diagnosis of bilateral dermoid cyst of the ovary was noted on the basis of hyperechogenic lesions on both the sides, ma'am. The ultrasonographic image has been shared, ma'am. The patient then routine investigations were sent, and the patient underwent total abdominal hysterectomy with the bilateral salpingo-oophorectomy. Grossly, both the ovaries were cystic, ma'am. Right-sided ovary was measuring 20 cross 20 centimeters, and the left ovary was measuring 6 cross 6 centimeters, ma'am. On cut section, 500 ml of hemorrhagic fluid was drained, and right ovary with cheese ball floating and hair, sebum, teeth was noted, ma'am. Left side ovary also showed presence of locules, hair and sebum. On microscopy, we had sent the specimen for HT. Ma'am? Hello? Ma'am, am I audible?
Yeah, carry on.
Ma'am, and we sent the specimen for histopathology, ma'am, and the microscopy showed the cyst wall lined by stratified squamous epithelium along with skin adnexal structures like hair follicles, ma'am, and derivatives from all 3 germ layers was present, ma'am. Introduction: a dermoid cyst is called a mature teratoma as a mature teratoma, as it's a sac-like structure which is a growth. It contains structures such as the hair, fluid, teeth, and skin glands, and it can be found on or in the skin. In some cases, even thyroid and brain tissue is present, ma'am. This occurs in the reproductive age group, ma'am. Since it is occurred in a 56-year-old lady, this is a rare case, ma'am. And the chances of malignant transformation is close to about 0.1 to 0.5%, ma'am. Endometriosis can be coexisting with bilateral dermoid cysts, ma'am, of both the ovaries, and that is a rare scenario when it occurs. This association has clinical relevance because endometriotic pathology can reveal a silent teratoma with bilateral ovarian localization. In general, removing the dermoid cyst is not an emergency procedure, but if the dermoid cyst ruptures, it becomes inflamed or causes pain, fever, a patient should seek immediate medical care. Treatment would depend upon the patient's age. And in this case, since she was 56-year-old and bilateral dermoid cyst was there, and she also had adenomyosis, so we did an total abdominal hysterectomy with bilateral salpingo-oophorectomy, ma'am. Ovarian teratomas commonly has an indolent course and presence with abdominal pain due to complications such as torsion, hemorrhage, or infection. Spontaneous rupture of teratoma is a rare and due to its thick wall and is usually occurs in the peritoneal cavity. Rupture into the hollow viscous or adhesions is extreme complication which may present as perforation.
For discussion, ma'am. Sorry to interrupt, ma'am. It's time for discussion, ma'am.
Okay. What made you present this case, ma'am? What is rare in this case?
Ma'am, rare in this case as in usually teratomas, mature cystic teratomas are seen in a reproductive age group, ma'am. Since this has occurred in a 56-year-old, ma'am?
They can be seen postmenopausal. Tell me one thing, if this is occurring in a postmenopausal lady and if it is converted to a malignancy, what will be the malignancy you see in this?
Ma'am, squamous epithelial metaplasia would be there, ma'am.
I'm asking you malignancy, talking about metaplasia.
I'm sorry, squamous cell carcinoma can be there, ma'am.
So that was final histopathology did not reveal any squamous cell carcinoma.
No, ma'am. No, ma'am.
Okay, fine. It's okay. No discussion from my side.
Yes. Thank you.
Okay.
All you judges, the session has been completed, ma'am. Thank you for your patience and cooperation, ma'am.
Dr. Lavanya, can you please share the email where we're supposed to send this back?
The marks and all, we have to send the same mail. We can send it, Lavanya.
Yes, ma'am. I'll mail you, ma'am. I'll mail that, ma'am.
So the other 3 students are not there.
Not there, ma'am. Yes, ma'am.
I think
Kavita Mani.
Prabha and Kavita Mani.
Yeah.
Yes, ma'am. Not there, ma'am.
Fine.
Okay. Okay.
Okay, ma'am.
Thank you, Dr. Lavanya.
Bye, Dr. Shamala. Thank you.
Thank you, all the postgraduates.
Dr. Lavanya? Dr. Shamala? Bye, madam.
Thank you, madam.
Thank you, ma'am.